senior academician and clinician with over 43 years of experience in Ayurveda. He retired as professor and HOD of Department of Panchadharma from Government Ayurvedic College, Tirunelveli, and is recipient of the Government of Kerala Best Doctor Award in 2009. He has held several key academic and advisory positions, contributing significantly to the advancement of Panchadharma and Ayurvedic education. Please join me in welcoming Dr. G. Vinodkumar sir. Now I would like to welcome our moderator, Dr. Associate Professor, Department of Panchadharma, Government Ayurvedic College, Pune. We warmly welcome you, ma'am, and look forward to your guidance in this session. Now I welcome Dr. G. Vinodkumar sir for the opening remark.
Good morning to everybody. Respected Principal Dr. Sindhu, Chairman of the Sathyanarayana, Dr. Remia, the speakers of this session, Dr. Najeeb, Dr. Sathyanarayana, and Dr. Parvathy, delegates, teachers, my dear students. As a former student and faculty member of this esteemed institution, I am delighted and privileged to take part in this seminar in connection with the centenary celebrations. It is my privilege to welcome you all to this session of the seminar on the management of prediabetes and insulin resistance to closely linked conditions that are rapidly becoming defining health challenges of our life. Prediabetes is not merely a warning sign, it is a crucial window of opportunity. It represents a reversible metabolic state where timely intervention can prevent or delay the onset of type 2 diabetes and its complications. Insulin resistance, the underlying mechanism in many cases, reflects a deeper imbalance in metabolism, often driven by lifestyle factors, stress and environmental factors. In India, more than 9 crore people are suffering from diabetes, whereas in Kerala, the capital of lifestyle diseases, 18 to 25% of people above the age of 18 is suffering from this. Globally, organizations such as World Health Organization and American Diabetes Association emphasize early detection, lifestyle modification, and integrative care as the cornerstone of management. However, beyond statistics and guidelines, this topic invites us to rethink Prevention as a continuous process rather than a reactive method. In India, where metabolic disorders are rising sharply, we are uniquely positioned to integrate modern medical evidence with traditional health wisdom. The principles of balanced nutrition, physical activity, stress regulation, and individualized care central to Ayurveda, align closely with contemporary metabolic sciences. This integrative perspective is especially relevant as wellness-oriented healthcare models continue to expand. Given the growing interest in holistic health environments, we have to strengthen Ayurveda-based healing spaces in public and private sector institutions in this direction. Understanding metabolic prevention is not only a clinical responsibility, but also a foundational pillar for preventive wellness services. Today's seminar brings together expertise from clinical medicine, lifestyle science, and integrative health systems. As more, I look forward to a thoughtful exchange of knowledge, practical strategies, and actionable insights that can guide both practitioners and wellness institutions in addressing prediabetes and insulin resistance effectively. Let us use this platform to deepen our understanding, strengthen interdisciplinary collaboration, and move from awareness to implementation. Thank you.
Thank you, sir, for that insightful words. Now, for the opening lecture, it is my honor to introduce our distinguished speaker, Dr. Najeeb, sir, an expert in endocrinology with a unique integrative medical background. He completed his DM from Government Ayurveda College, Vinodkumar, and his MBBS from Children's State Medical University, Georgia. He further specialized with a postgraduate diploma and master's degree in endocrinology from University of South Wales, a former lecturer at Government Medical College, Ayurveda. He is also a member of leading international bodies, including the Endocrine Society, American Association of Clinical Endocrinology, and American Thyroid Association. Today, he will be speaking on management of prediabetes and insulin resistance. Please join me in warmly welcoming Dr. Najeeb, sir.
Okay, excellent. So today's topic is prediabetes and insulin resistance. As we all know, as far as diabetes is concerned, much complicated disease. We all know multi-system disorder. Almost every system get affected. So this is a stage. What's the importance of prediabetes and insulin resistance is? This is a stage we can revert the clinical scenario and save the life of the patient. So that's the important things regarding today's lecture. So let's move on. Yes. So these are the learning objectives for today's topic. Just review the epidemiology of the type 2 diabetes and prevalence, insulin resistance, etc. Then the pathophysiology mechanisms. Then we move on to lifestyle and pharmacological strategies. Then we will discuss the emerging therapies and precise medicine. These are the things we are going to discuss. So before moving on to the topic, this is a global order regarding the type 2 DM and insulin resistance. Look at this. The 2045, look at the predictions of the American Thyroid Association, American Diabetic Association. We are predicting in 2045, 800 million people will get affected with diabetes. This is a global warning nowadays. So look at the scenario. This is the statistics. 101 million diabetes cases. The second line is very important. The pre-diabetes is 136 million pre-diabetes. Okay, so second line is 136 million pre-diabetes. So high visceral adiposity phenotype and rapid abdominal. This is the epidemiology. Indian scenario is concerned. So second line is very important. The pre-diabetes is more common than exact diabetes. So let's move on. Then the pathophysiology. Please understand this pathophysiology before moving to the treatment side and understand the disease. This is very important scenario. This is the defective insulin receptor signaling. Even though the insulin is produced, the signaling mechanism gets hampered. So how and why it's happened? Let me discuss. There's a group 2, group 4. We all know the group 4 is the glucose transporter. So this transporting mechanism gets impaired and hepatic gluconeogenesis is increased. That means more and more glucose is produced. More and more glucose is produced. Then we have beta cell compensation. This is the very, very important thing as far as the pre-diabetes is concerned. How beta cell get exhausted. Then move on. There are so many reasons. This is a prime reason. It's a primary drive for insulin resistance. Is this one? Chronic insulin resistance is the main cause for the beta cell exhaustion. How this chronic insulin resistance get affected? So this is caused by the cellular obesity, as we all know. Then the sedentary lifestyles, then high calorie diet. These all leads to the chronic insulin resistance, and especially the muscles, the liver, and the fat become resistant to insulin. This is how the pre-diabetes is developed. And beta cell compensate for producing more insulin. What happens for the cells, for the liver, the fat cells, all the liver functions and other things, tissues resistant to insulin? What happens? The pancreas and beta cell secrete more and more insulin, more and more insulin. But next scenario is beta cells compensate for producing more insulin. So chronic so beta cell produce more insulin. Then what happens? Eventually the beta cell dysfunction. Happens. So these are the main things which leads to the pre-diabetes. It leads to the insulin resistance. Okay. Next slide, please. So the second topic is regarding insulin resistance. Beta cell exhaustion is the glucotoxicity. This is second is glucotoxicity. What happens is the persistent hyperglycemia, that is even in pre-diabetes, can damage beta cell. Contrary to your knowledge, pre-diabetes also hyperglycemia can develop. Maybe it is misdiagnosed or undiagnosed or unrecognized. So hyperglycemia is common in pre-diabetes also, which leads to beta cell dysfunction. Then we have high glucose causes. These are the causes. First is oxidative stress. Then we have the mitochondrial dysfunction, and then we impaired insulin gene expression. Then beta cells have low antioxidant capacity, making them more vulnerable. This is the mechanism of the pathophysiology which leads to more and more beta cell destruction. So treatment part, whether it is Ayurveda, homeo, or the modern part, this pathophysiology, understanding the pathophysiology is very, very, very important. Because as you all know, the preserving the beta cell is the mainstay of treatment. Preserving your beta cell is the mainstay of treatment. Then how we can preserve this? Reduce the oxidative stress. The oxidative stress, the beta cell cannot manage the stress. The antioxidant property of the beta cell, unlike the other cell, is very, very, very low. It can lead to glucotoxicity. That means the body, the liver cannot handle more and more glucose. The more glucose is produced, which the high calorie food, sedentary lifestyle, all the processes we explained in the previous slide, all can contribute more glucose production. The liver doesn't like more and more glucose coming. The glucose itself causes toxicity. It can lead to beta cell damage, overstress, overworking, antioxidant property is less. The beta cell can become damaged and get exhausted. Then we have another toxicity which leads to the beta cell dysfunction is lipotoxicity. This is very, very important in youngsters. In younger generation, the lipotoxicity is the major cause which leads to the beta cell exhaustion. So elevated free fatty acid from the visceral fat, accumulation inside the second line is very important. Inside the pancreatic beta cell, the fat get deposited. It can lead to interfere with the insulin secretion pathways and it induces the apoptosis. Apoptosis, you all know, cell suicide or programmed cell death. It can reduce the damage because it's more and more damage happens. Then it induces the apoptosis commonly in obesity associated prediabetes. So these are the mechanisms in different scenarios. In obesity associated prediabetes, lipotoxicity leads to prediabetes. Obesity associated lipotoxicity leads to prediabetes. Youngsters, in the previous slides, as you all know, for youngsters, glucotoxicity and is reduced and antioxidant properties. This leads to big vessel damage. And in other things, lipotoxicity leads to big vessel damage. Then we have the chronic low-grade inflammation. This is very important as far as the management is concerned, because even though the blood sugar level is in the pre-diabetic or the normal stage, if you have underlying inflammation like arthritis, whatever it is, maybe chronic diseases, maybe SLE, maybe rheumatoid arthritis, maybe inflammatory disorders, whatever it is, underlying disease is there, any chronic inflammation is there, release more and more release of the interleukin 6, more and more release of human necrosis factor. These are the anti-inflammatory factors, substances, the cytokines which release in the blood. This itself can damage the beta cells. It leads to cause insulin resistance and direct beta cell damage. Direct beta cell damage. These are the pathophysiologies which leads to damage of the cells. For the PG students and the upcoming UGs also, please understand the pathophysiology. Then we move on to the treatment already. So this is the mechanism underlying inflammatory. That is what happens in inflammatory condition. Always when you check your blood sugar or the patient's blood sugar will be on the higher side. When the inflammation subsides, the sugar backs to normal. Okay. So this is because interleukin 6 is released, and these are the inflammatory cytokines, and human necrosis factor is also released. Then we have this all contributes to beta cell damage. Then we have the genetic susceptibility. All know, whenever the patient comes to your clinic, comes to your OPD, always take their family history. It's very important. Even though the first parents are not diabetic, their grandparents may be diabetic, chronic diabetic patient. Ask about their family history, ask about their cardiac history like myocardial infarction or any congenital heart disease, etc. This is very important. That gene specific to that disease may be inherited to the next offspring. So family history is very important in the treatment guideline. So in this, the type 2 certain population, including South Asian, have low beta cell reserve. This is more common in India nation than this, because we have beta cell reserve is much less, and higher visceral fat tendency. This is especially relevant in India. Then we have the endoplasmic reticulum stress. These are the things which leads to prediabetes condition, beta cell damage. How it happens? The chronic demand for insulin synthesis and misfold insulin protein and activates the apoptotic pathways. Whenever the endoplasmic reticulum undergoes stress, the folding of the insulin get damaged. This folding of the insulin protein, it's a protein. Insulin, we all know it's a very protein, we all know. These chains are there. So insulin protein gets misfolded. This misfolded protein, as you all know, becomes ineffective. Then hyperglycemia develops. Hyperglycemia, glucose overload will come. The liver, it affects the pancreas, it does get damaged. It also leads to the inflammatory stress, and the endoplasmic reticulum stress also leads to prediabetes syndrome. And endoplasmic reticulum stress, as we all know, endoplasmic reticulum is concerned as far as the apoptosis is concerned. Endoplasmic reticulum is absolutely important organelle, cell organelle. So endoplasmic reticulum proper function is always important. We all studied in the earlier physiology classes, so pathology classes, we all know this endoplasmic reticulum dysfunction leads to impaired apoptosis and impaired glucose handling. It can contribute to the prediabetes. Then we have the aging and environmental factors. This is also, as you all know, as age is an increasing age, insulin resistance gets developed. Ultra-processed diet is ultra-processed. Do not consume ultra-processed diet. Never always go for the semi-processed one, and sleep deprivation, stress, endocrine disturbance, all these can lead to insulin resistance. Even though the patient is taking so much medication, if they get deprived sleep, only 2 hours, 3 hours sleep, the insulin resistance will develop. Your glycemic control get affected. The proper duration, timing of the sleep, all these things you can handle. Here the situation we can intervene. As Ayurvedic doctors, we can intervene in this prediabetes state. Then ask them to change their lifestyle monitoring, ask them to their sleep pattern, ask them to their exercise lifestyle, behavior, habits, etc. So that we have why this increases probably, especially in India, why this pre-insulin, pre-diabetes and insulin resistance is in the increasing state. Why? It's earlier on, obesity is the main thing, and childhood insulin resistance is genetically predisposing factor, increased visceral adiposity despite the normal BMI. This sentence is very, very important. Even though the patient is having normal BMI, the obesity is, the visceral adiposity should be there. The visceral adiposity, even that we call it as thin fat phenotype. This is a new term, thin fat phenotype. Even though the patient is slim, visceral adiposity on the higher side, it can lead, it is more dangerous than an obese person. It can lead to insulin resistance. It can lead to prediabetes. Then we have reduced physical activity or surveys. We are saying then highly refined carbohydrate intake. Then pre-diabetes progress faster to diabetes due to earlier beta cell failure. Then we move on. These are the key concept in the pre-diabetes. This is the key concept is the insulin resistance. The summary of the so far, the pathophysiology. The key concept is insulin resistance appears first. What happens next is the compensatory hyperinsulinemia. That means high glucose inside the blood. What leads to glucotoxicity and hypotoxicity, we explained earlier. Increased glucose load leads to hepatic dysfunction and pancreatic dysfunction. Increased lipids also leads to deposition of fat to the beta cell, leads to the impaired pancreatic beta cell function. What happens next? The inflammation will follow. When what happens next? After the inflammation, what happens? The juvenile process factor, interleukin 6 cytokines gets released, oxidative stress is increased, beta cell unable to handle the oxidative stress because, as we said, it has low antioxidant property. What happens next? The insulin resistance will develop, it leads to dysfunction, and then the apoptosis. Apoptosis means damaged cell, renewal cell, suicide of the beta cell. The damaged beta cell, exhausted beta cell get damaged and removed from the body. Then leads to apoptosis and leads to the diabetes. This is the pathophysiology of the pre-diabetes to the diabetes. Okay. Then we have, this is the clinical implication. This is a major clinical implication. So by the time, this sentence, this slide is for all the audience, this slide is very, very, very much appreciated slide and sentences because most of the patients, most of the students, most of the doctors say that, let's see, for the diabetes treatment to begin. For the diabetes treatment to begin. As by the time you diagnose a fasting glucose is more than 140, by the time you diagnose a T2 DM, the 40 to 50% of the beta cell is already damaged. That is the important thing. So when you discuss with the patient and diagnose your patient diabetes in the pre-diabetes stage itself, you can reverse this scenario. That is the important thing. Always communicate with the patient that by the time you diagnose, the 50% of the beta cell get damaged. So never wait until the FPS is going beyond the 140 mark or HbA1c is going beyond the 6.5. Always intervene in the pre-diabetes state itself. Then only the role of a doctor comes into play. Especially as far as you is concerned, pre-diabetes, reversal of pre-diabetes to diabetes is absolutely important for, especially for you guys. You can reward this with life changes, food changes, no medication. You can reward this diabetes to be a pre-diabetes to normal stage. Once it crosses the limit, it is very, very difficult. Because the complication already sets in, beta cell is already exhausted and more than 50% beta cell is already lost. Then we move on. Then it promotes cancer prevention. This is the program. This is American Diabetic Association has introduced a program. You can check in the website, it is there. Diabetic Prevention Program. It's a new program launched by the American Diabetic Association. This is actually more relevant for the pre-diabetes. This is a 2025-26 update. This is more relevant for the pre-diabetes. In this stage, we can reverse it to the normal state. These are the things which promotes what it means. It promotes a modest weight loss. It seems nothing. Just 5 to 7% weight loss can contribute much. Beyond your thought, beyond your imagination, even 5% weight reduction can change the scenario. That means one more thing, the 5 to 7% weight reduction and the lifestyle modification, the duration you suggest is very, very important. It's not a magical number, it's not a Ayurvedic thing, it's minimum 6 to 12 months. It requires minimum 6 to 12 months. Always suggest your patient to follow these things. The things you have to follow is next slide. I will explain. Follow these things for the next 12 months. Then your result will come. And follow the patient at least monthly. 1 year is absolutely important for the reversal of pre-diabetes to diabetes. Then we move on. Here are the programs. These are the diabetic prevention program goals. Simple things, there are 12-14 goals. First line we have track, get more active to prevent. The first thing is more active. Rather than sitting, just more active. The second thing, track your activity. This is very, very important. How much minute, how long, the duration of your exercise, duration of your walking, all these things are important. Track your physical activities. Next thing. And third thing is eat well and track your food. It's very, very important. Even actually they are telling them in explanation, shop and cook your food. That's the thing. It's written nothing in Ayurvedic. New guideline, shop and cook your food. That indirectly means that they not food consumed from the outside, high calorie food. These simple things can reward things. So there's not only a simple line, 12-14 things. Goals are there. Please follow these goals and then burn more calories than you take in and manage stress and pop with triggers. The stress management is also important. Then we have keep your heart healthy. This is walking, etc. Quit smoking, off you all know. Then take charge of your thoughts. This is also very important. Then get support. Then eat well away from home. When you travel, this is advice. This is a new advice. When you travel for 2 months or 2 weeks to abroad or outside the Kerala, eat well. Whenever you consume everything in an orderly manner, systematic way, when you move out of your home, when you do the travel, you will take everything. Ice creams, desserts, all these things. So do not do that. Follow your food, track your food, eat well when you are away from the home and stay motivated. I can do it, I can reduce my 5%. That's an important thing to keep in mind. These are the things we can reduce. Then pre-diabetes diagnostic criteria. This is very, very important. Not the diabetes HbA1c is normal HbA1c is 5.7, process 5.7. We call it as pre-diabetes. Up to 6.5 we can reverse. The goal, keep in mind, is up to 6.5 we consider it as, especially for the Asian scenario, for the Americans and Europeans, up to 5, above 5.5 they start metformin. For the Americans, they start metformin if the HbA1c is more than 5.5. Indians and Asian population, they consume lot of rice. Our genetic predisposition, all these things, we put the cutoff value 6.4. So 6 rather than 5.5, keep it as 6.4. So once it passes, we call it as diabetes. So pre-diabetes is 5.7 to 6.4. We can reverse this by doing all these things. And then these are the diagnostic criteria. Fasting glucose, if it is 100 to 125 milligram, we all know we are having so many persons having 100 FPS. Actually, it's a pre-diabetes condition. Normal FPS should be less than 100. If the FPS the lab value is correct, it should be within below 100. If it crosses 100, always think about the pre-diabetes. Always think about the pre-diabetes. In two scenarios, whether your HbA1c is greater than 5.7 till 6.4, you consider as type 1 pre-diabetes. And if your fasting glucose is greater than 100 to 125, you consider it as pre-diabetes. And otherwise, other tests we all know, oral glucose tolerance test. If it is inconclusive, go for the oral glucose tolerance test. Take consume 75 grams of glucose and take the measurements after 2 hours. Gap is there. One time we can available the net or GTP test. If it is 141 and you can confirm the diagnosis with diabetes, then one more thing, repeat annually if indicated, all these things repeat. Then experiencing actually, as all know, the average lifespan of the red blood cell is 120 days. It's divided by 30, it's 4 months. So it's a value, average blood glucose level, reflection of the average blood glucose level of the last 4 months. One more thing, experiencing do not advise you taking every fasting, nothing. Whenever you do experience, you get the exact value. Fasting or doesn't matter. Fasting or post-plan, it doesn't matter. For the experiencing, for the reflection of the last 4 months. So, suggest the patient to do the experience not in every month, once in 4 months is already required. Then only you can do it. Sometimes it can appear. If you start the treatment, the patient comes with a low FPS and EPS value, experience is still elevated to 9 or 8.9. And aware them and inform them, discuss with them as the reflection of the 4 months period, we take another 2 to 3 months to get back, comes back to normal. Okay, so always keep it in mind. One more thing, whenever you have experience in the higher side, even after your treatment, always think about the hemoglobin pathologies. Blood abnormalities can lead to elevated HbA1c level rather than diabetes. The hemoglobin is carried. So the hemoglobinopathies are there, polycythemia vera is there. If you have hemoglobin comes under the high rate greater than 80, polycythemia vera is nowadays very common. So that for what I am telling this is, whenever the diabetic patient comes, not always do this test alone. Always go for CBC at least complete blood count. Because this impaired RBCs or polycythemia vera or high hematocrit greater than 55% all can give you false values of experience. So make sure the patient doesn't have an underlying hematologic pathology is there. Okay, make sure. So that's important thing. Polycythemia vera is very common. It's a hemoglobin is greater than 80. 17 was earlier, now it's 80. Or hematocrit greater than 55. We consider polycythemia vera. It can lead to so many, it increases the blood viscosity and it leads to the coagulation disorders. It can give clot disorders, etc. Then we have the cardiometabolic risk in prediabetes. This is how the cardiometabolic risk happens because endothelial injury is very common. As well as the diabetes, pre-diabetes, diabetes and non-diabetes. When compared to non-diabetes, the endothelial injury is very on the higher side. That's why we suggest the patient to start the treatment immediately as well as the diagnosis of diabetes is confirmed. Because it can lead to endothelial damage. Endothelial damage as compared to non-diabetic patient, the risk of actually we are inviting the cardiac diseases, atherosclerotic diseases. For example, let me explain another way, because in blood vessels, it moves the blood vessels, the blood moves in a normal laminar flow. You all know something physics. The laminar blood moves in the blood vessels in the laminar flow. When the atherosclerosis happens, or in the diabetes patient, the flow, the velocity of the speed of the blood can change. It changes to turbulent flow. What happens? The turbulent flow can lead to endothelial injury. Of course, the normal laminar flow is silent in nature, doesn't produce any sound. Okay, if it gets turbulent, the turbulent flow is happen, it can lead to endothelial injury. The speed, the blood vessel is in such a way that it flows smoothly. If it changes to turbulent flow, the speed, the velocity of the movement of the blood can change. It leads to stasis of the blood and accumulation of cholesterol, lipid particles in the blood vessels, leading to plaques and also. This scenario, this phenomenon is on the higher side in diabetic patients as compared to non-diabetic patients. So there is no immediate response. Always suggest your patients or relatives that there is no immediate changes. It happens after 10 years or 8 years. So diabetic patients have a complication appears only after 8 years, 10 years, 15 years. In the future course, it affects. In fact, a percentage above the 10, for example, HbA1c is 12, HbA1c is 11, HbA1c is 13, even 1% above 10 reduces the life expectancy by 2 years. Because after 15 years, 20 years, these atherosclerotic events will occur. It might be ischemic stroke, it might be MI, it might be other abdominal aneurysm or any other type of aneurysms like this. Anyway, it happens to your or diabetic food, diabetic amputation, all this can change your life expectancy. Okay, for example, when a person is living, maybe expected to living for 80 years, if the HbA1c is always on the 14 or 30, as I said, 2 years for 1%. If it is at 14, HbA1c stays for long, 4 to 8 years. If the person is supposed to be living at 80 years, died at 80 years, will die at 70 years. The patient cannot understand, you reduce the life expectancy. Actually, if you are not taking the diabetes, you are not addressing the diabetes wrongly. Okay, so these are the endocrine injury, this leads to cardiac diseases and atherosclerosis progression and metabolic syndrome overlap and NFALD and MSALD is association. So non-alcoholic fatty liver disease and MASLD is the metabolic associated liver disease, steatotic liver disease. So abnormal metabolism leads to accumulation of Okay, back in action. This side. Look at this endothelial dysfunction we have. So far we are discussing the risk factor for the atherosclerotic disease, especially the MI, for the diabetic patients. So there is the higher side. Always think about the future. Always the prediction should be in your mind that endothelial injury is simple in one word. In one word, forget everything. The endothelial injury is common. More in diabetes and prediabetes as compared to non-diabetes. It can be anywhere. It can be anywhere. It can be inside the brain. If it happens inside the brain arteries, what happens leads to stroke, cerebral hemorrhage, stroke, etc. Though it's a common. The second thing we see, if it happens in the endothelial injury occurs in the vascular coronary arteries, the myocardial infarction will follow. If it happens in any other aorta, aneurysm can develop. The thrombus, what's the thrombus and clot difference? The clot is stationary and thrombus is moving clot. It happens, the DVT can happen and thrombus formation moves anywhere. Even the amputation may be done in some cases. So thrombus can move anywhere. It's a moving clot, we call it as thrombus. This is high risk. Then we move on to the lifestyle intervention. This is diabetic prevention program by the American Diabetic Association, evidence-based medicine suggestion. This is not a WhatsApp, this is not a YouTube channel advertisement, this is evidence-based. Actually, they can easily suggest a patient that 150 minutes per week is enough to protect your heart, brain and diabetes. Just 150 minutes per week. So 150 minutes divided by 7, just imagine. Just 20 to 30 minutes a day is enough. That is another suggestion. Another suggestion is nowadays everyone is working from morning to evening, late night. Use your workplace as this 20 minutes walk. Use your workplace. Do not use lift. Use the staircase and go to the canteen and nearby places by walking. Never take your scooter, everything. Use your workplace at the railway station, the bus stand. Use minimum at least 1 kilometer to the platform run, walking, etc. All this comes into play. This is the indirectly we are promoting our heart health, cardiac health. So this 150 minutes is this is enough. But we moderate exercise is enough, and this one 5 to look at that sentence. Just 5 to 7% weight loss can lead to 58% of risk reduction. These are the simple advices you can give to your patient. Then they will follow you. Then they will obey you. Otherwise, they might think, there is no use. 1 kg, 2 kg, there is no use. No, it's 5 to 7%. This is actually thousands and thousands of patients will go analyze. After the research methodology scientists follow up that, and with proper follow-up, all these evidences are collected. So, if you do by 5 to 7% weight loss, it gives you 58% of risk reduction. In long-term benefit, this is what I was telling. In long-term benefit, actually for 15 years, is very good. Over the 15 years, it can increase your life expectancy also. And we move on to nutrition strategy. This is also evidence-based one. This you can follow very easily. There is a low refined carbohydrate intake can prevent the prediabetes, and high fiber greater than 25 grams per day can prevent and revert your prediabetes, and Mediterranean style diet is also advisable and reduce the ultra processed food. It should avoid, especially in diabetic patient. Then, whom we start the pharmacology therapy? To whom? Who are the target patient with whom we target give the medication? This is very important. So high risk prediabetes. For who are the high risk prediabetes? The father or mother is extremely diabetic. They have the family history of cardiac diseases. All these things are there. They are in the verge of developing into DM, like HbA1c or disease. Always start with medication. Always start with medication. And BMI is greater than 35. You all know 28 above is not ideal. If it is greater than 35, do not never think about any other lifestyle modification. Along with lifestyle modification, medicine is warranted. So age less than 60 years means aggressive therapy and history of gestational diabetes for the females, gestation GDM for every female who have the GDM, 10 to 15 years later diabetes will come. Definitely diabetes will come. In that case, metformin is very, very effective. And later I explain the medication. So this GDM is also important. Always for all the lady patients, always ask the history about the GDM. Gestational diabetes is very, very important history. It can travel to our diabetes after 10 years or 15 years. Probably 10 years. Then we have what are the metformin medical use. Nowadays we are using, not nowadays, from the initial years itself, metformin is a right drug of choice for the pre-diabetes and prevention of conversion of pre-diabetes to diabetes. Metformin is ideal. Other uses of metformin is metformin induces ovulation. It can correct the ovulation. That's why it's advisable in PCOS syndrome. In PCOS, we are using metformin, and metformin dose start from 500 milligram available dose. The maximum allowable dose is 2 gram per day. Not think that an overdose, no. Up to 1500 2 gram, 1500 milligram, 2000 milligram is safe. Metformin is really safe unless your GFR is less than 30 ml per hour. So this GFR is common. There is no contraindication for giving metformin. Only thing associated with metformin is some gastric issues. Gastritis can develop, and gastritis can develop by taking after food. Ideally, advice before food. After food, patient is suffering from severe gastritis. Do not stop the drug. You can give it after food. And metformin reduces the insulin resistance and reduces the fat, so it's weight reduction and reduces, corrects the ovulation. Then PCOS is very good, and it is reduces the hepatic glucose production. Another function is liver glucose production gets reduced and improves the insulin. That is very important. Even though our pancreas industry is producing enough insulin, because of the insulin resistance, the sensitivity of the insulin is very, very low. When you administer the metformin in ideal optimal dose, it can increase the insulin sensitivity, and this is, and the third sentence is very, very important. This is most effective in patient. I don't need medicine, these are the normal questions, suggestions there, the patient is commenting. So even though because you are lying, you need this medication, metformin. Otherwise your medication, you can metformin, either way you can treat, all these things can easy. Then cost effective and safe. Metformin is very, very cheap. It's available in India very cheap. So these are metformin. Then we have another one, GLP-1 receptor agonists. For what purpose you are studying all this? For what purpose I am sharing all this thing to you? When a patient comes to you with also medication, you should be familiar with the names at least and the mechanism of action at least. Which drug I have to stop, which drug I can give either medication with this drug or not. That's why I am familiarized you with these important names. Otherwise, no, at least familiarize this thing. First is the metformin. Even if you want to give a trial of Ayurvedic medicine, give to our gap between allopathy metformin medicine and Vishagadari. If you are giving Vishagadari, so at least 2 hour gap is enough. What is the role of adding an Ayurveda medicine with the allopathy drug? The prime thing is, if the patient is currently taking 2 gram metformin, for example, 1000 1 gram morning, 1 gram evening. If you are adding Vishagadari, I don't know exactly the medicine anyway, Vishagadari, if you are adding, we can reduce the 2 gram metformin to 1 gram after 3 months. You can reduce the metformin to 1 gram, put one time 1 gram metformin, then you can increase your Vishagadari dosage. That's a simple advice. At least keep 2 hour gap between the medicines, two systems of medicine. Then we have GLP-1 analog. GLP-1 analog is nowadays very common. That is, this GLP-1 receptor agonism or the thing is, the main function of GLP agonist acting on it delays the gastric emptying. So when you eat your breakfast, then after 6 hours or 8 hours you get up, you become hungry only. It reduces the airway salinity also. Even consuming even little food, you get up, I am okay, and my appetite is okay now. So it reduces the salinity and delay the gastric emptying. So these are the 2 important functions GLP-1 agonists do. The liraglutide, semaglutide, these are the injections that are available now. The GLP-1 agonist, receptor agonist injection is available. The advantage of this injection is it only once weekly injection. So you heard only about the insulin only. This is another treatment. GLP-1 agonist weekly one injection. That one vial costs around 4,000 rupees, but it's for 1 month. It lasts for 1 month. So if you can afford, GLP-1 agonist is the latest technology. It's a new injection we are currently using nowadays. Enterprise is routinely using for this. I think for the last 4 years I am using this one. The patient can afford. The thing is, it has one side effect. That's why I explained the thing physiology earlier, how it's the mechanism of action. Because it causes gastric delay, and gastric emptying is delayed, and in early salinity, it affected the gastric glucose receptor. So it later what happened, the bloating will develop, acute gastritis will develop, some abnormality related to stomach, daily weight will appear sooner or later. So I want routinely recommending this first time therapy always have normal insulin. The patient doesn't respond to insulin, not really think about it. Nowadays, the new 25-26 guideline suggests the anti-obesity drug is this one. This liraglutide and semaglutide GLP according to used as the anti-obesity drugs. Okay, the new generation anti-obesity drugs also comes under this class, and it improves the insulin sensitivity. The same thing what happens with metformin. Then cardiovascular benefit is on the higher side. And consider an obesity with the insulin resistant. If the patient is obese with high insulin resistance, we consider this GLP-1 agonist. Then we have SGLT inhibitors nowadays very common. You all know SGLT inhibitors, dapagliflozin, all this is available. This is extremely safe. This is actually exclusively used for proteinuria. This is high cardiac benefit is also because it can prevent the heart failure. All the diabetic patients become heart failure is predictable after 50 years. SGLT inhibitors are giving nowadays renal friendly and the proteinuria is also eliminated because it's very effective in proteinuria also. Renal friendly medication only side effect is sometimes associated with the UTI. So it's excreted, the glucose is excreted via the urine. The urine glucose will be always shown plus, nothing mind, never mind, but it causes because of glycosuria. The urine contains glucose, it leads to urinary infection. That's the only thing that happens. That how to counter this is taking so much water. 4 to 5 glasses of water with this drug can reduce the insulins. The study in high-risk prediabetes may alter the disease trajectory. So prediabetes, metformin is safe and this SGLT inhibitor is also safe. What is SGLT inhibitor? The mechanism of action for this such type of 10 minutes, 5 minutes. Okay. So SGLT inhibitor means when you take the nephron structure, we all know the proximal converted to good, distal converted to glucose-friendly, distal converted to good and collecting that. The nephron structure we all know, we are all doctors who study the basic things. The drug, the proximal converted to good, where the glucose and sodium is transported together. That's the role of sodium here. When the sodium moves into the blood things, to the nephron, that barrier, the glucose, whenever the glucose moves in, sodium moves in, it always take the glucose along with this. We call it as a co-transport. The co-transport. So, when the sodium moves in the cell, it's carrying the glucose along with the sodium into the cell. If you block this sodium channel, the glucose entering into the cell get reduced. That's the main principle. SGLT inhibitors. You got it? That's SGLT receptor blockers. That's the main mechanism of action. So that entry of glucose and cell get reduced. Then we have the metabolic bariatric surgery is available. If your patient is very obese, suggest the bariatric surgery. That one thing is indicated BMI is 40, greater than 40. Bariatric surgery is advisable and high remission rate is the negative side of this bariatric surgery. After 10 years it comes again. For 10 years only, then improves insulin sensitivity dramatically. That word is very important. Bariatric surgery improves the insulin sensitivity very dramatically, and long-term diabetes prevention is ideally suggested. These are the things we use in pre-diabetes. Then we have the precise medicine and future direction, what we do and what we are planning. And this is the genetic risk profiling and continuous glucose monitoring. You all know, you all familiar with the continuous glucose monitoring, I think. Continuous glucose monitoring and AI-based risk prediction also important. Then digital lifestyle intervention platform. A few got 1 minute regarding the continuous glucose monitoring. As physicians, always patient ask you whether it is ideal or not. The continuous glucose monitoring is a device under the skin. We are putting inside under the wrist, under the skin. It detects the blood glucose, not the blood glucose. It detects the glucose level in the interstitial fluid. Not the blood glucose, the continuous glucose CGM machine. It costly nearly 1 lakh rupees. Sometimes good company it's 5 lakhs. So continuous CGM machine put under the skin. It detects continuously monitoring blood glucose in the interstitial fluid. But the disadvantage is it's always 50 to 20 milligram glucose value less than the blood glucose value. Because it's not measuring the blood glucose. It senses the changes in the interstitial fluid. So it lags behind 15 to 20 milligram glucose as compared to the blood. That's only, but you get familiarized. You need needle prick is required and to get the accurate value. That's the only negative side. And also one negative side is costly and very costly, but you can in some cases where a person is experiencing bouts of hypoglycemia and hypoglycemia, it's 24 hours, you need to monitor the continuous glucose monitoring. Okay, then we move on. Then the management algorithm. This is algorithm for you also. This is screen the high-risk individuals. Take the proper history, take the BMI, all these things you need in your OPD itself. BMI should be assessed, life history and family history, genetic history, everything should be taken proper history. Confirm the diagnosis. Confirm the diagnosis of all the 3 values if possible, at least FBS, PPS and HbA1c. Most of the patients have low fasting blood sugar value and some patients are high postprandial sugar. So always take FBS and 2-hour PPS. Not 1.5 hour, it's a 2-hour PPS is a American Diabetic Association guideline. Fasting and 2-hour PPS is ideal to diagnose whether the patient is pre-diabetes or insulin resistant. One more thing I need to remind you that nowadays the patients or the doctors are doing fasting insulin, serum insulin level. Actually this is not indicated. Actually this is not indicated in diabetic treatment, any guideline, nothing. This is actually only thing is to check your insulin resistance. If the blood is having hyperinsulinemia, that means high serum insulin, that indirectly or directly tells you that your body is insulin resistant. For someone who is reluctant to take medication, for any obese female, reluctant to take metformin or reluctant to take iron medication, confirm them with or explain to them with this result. That's only the indication. Serum insulin is on the higher side. You reassure them you have insulin resistance is there. That's only indication. Not routinely doing, routinely suggested. Then we have the metformin. So metformin if high risk patient, annual monitoring and cardiovascular risk category is very important. Then public health strategy in India is community-based screening is very good for schools, colleges, hostels, etc. You go and screening them for the pre-diabetes, very important in India. And workplace wellness program, conduct diabetes prevention program in your workplace at least yearly to make the awareness of the pre-diabetes and diabetes. Then school obesity prevention is a much appreciated program, and national diabetes prevention initiatives are on the pipeline. Then we have the key take-home messages. These are the 3 messages. And pre-diabetes is the most important thing is pre-diabetes is reversible. Once it's developed in the over diabetes is irreversible. So pre-diabetes is reversible and insulin resistance is modifiable. We have two types of risk factors for UTPs. It's a modified risk factors and non-modified risk factors. And the resistance is modified risk factor. Pre-diabetes is a reversible condition. And lifestyle remains the most powerful intervention rather than drugs. You are taking some medicine, doesn't mean that you can do anything. So the lifestyle modification is a prime thing, is a primary driver to reduce the insulin resistance. And early action prevents cardiovascular disease. And these are the take-home messages. And now the conclusion. Pre-diabetes represents a critical intervention window. It's an intervention window actually, pre-diabetes, and multidisciplinary and personalized approach to drug prevention is the future of endocrinology. And this is all about the pre-diabetes and insulin resistance. And thank you all.
Huge thank you to Najeeb sir for this session. Where expertise had made the topic come alive. Attendees who have any queries may please note down on a paper and hand them over to the volunteers. Moving on, it is my pleasure to introduce Dr. Sathyanarayana sir, India Ayurveda, Principal and Director, Research and Development of Munyar Institute of Ayurveda Medical Science. He completed his BA from SDM College of Ayurveda and his MD in Vaishnavi from Institute for Postgraduate Teaching and Research in Ayurveda. With over 25 years of teaching and research experience, he is a PG and PhD guide, accomplished researcher and recipient of several prestigious awards, including the Ayurveda Vishwaratna Award. His expertise lies in Ayurvedic pharmaceutics, formulation development, and clinical research. Today, he will be sharing his clinical experience in the management of prediabetes and insulin resistance. Please join me in welcoming Dr. Sathyanarayana sir.
यस्मिन् सर्वं यतः सर्वं यः सर्वं सर्वतश्चयः यश्च सर्वमेव नित्यं तस्मै सर्वात्मने नमः. Dignitaries of the days, today's session chair Dr. G. Vinodkumar sir, moderator Dr. Revya and my previous speaker Dr. Najeeb sir, and all the faculty members, the students, delegates. At the outset, let me extend my heartfelt gratitude to the organizers, especially Dr. Vinodkumar sir, Dr. Sindhu madam, and all of you for inviting me and giving me an opportunity to share my views on a concept, clinical experiences in the management of prediabetes and insulin resistance using Rasaushati. You may feel the title is looking something different than the one mentioned in your brochure. Dr. Vinodkumar sir, during the first conversation, requested me to highlight on Rasaushati, so I maintain the same title. We do not have any proper RCTs in Ayurveda on management of prediabetes, except a couple that are published, which incidentally I will show you. You may wonder why you should use Rasaushati for managing simple prediabetic condition which is preventable. But sir has already mentioned a few pharmacotherapy also which you must have observed. And we are seeing in today's scenario, even though the condition is preventable from advancing into next stage, we are seeing that even after a year of using all this lifestyle management, dietary management, diabetes is becoming overt. So we need to find out some such situations, scenarios and medicaments or pharmacotherapy with which we can manage this condition very effectively. And even when we observe the pharmacotherapy in Ayurveda for prediabetes or diabetic condition, you you may be observing so many herbal preparations, so many herbs, polyherbal products, maybe more kashayas in this region. Only a few resolutions are being clinically used. We have a long list, but only a few. So you may be seeing, say, Vinodkumar G, then you will have to think what other formulations I have, except for a couple of customers and some Shilajit containing products. I thought let me change today's topic slightly, giving emphasis on these aspects also. I thank Doctor for making my presentation easy so that all basic slides I can skip very quickly. So I will skip all these introductory slides which have helped me. And I know in our brochure I have seen that you had and you are having the speakers who are talking on the basic principles of understanding the concept of prediabetes or insulin resistance through Ayurveda, then the general line of treatment, then maybe the diet, then yoga. So yesterday also we had a couple of sessions. So I can skip all those things here so that repetition can be avoided. As Sir has mentioned, 3 different criteria, maybe fasting blood sugar, HbA1c level, and one more Sir has rightly mentioned, that is regarding the insulin resistance. Today we are much worried about insulin resistance, and that is the place where our products act extremely well at the receptor level also. So HOMA IR is what the test is being done nowadays. Fasting insulin level in the blood, fasting blood sugar, which are multiplied and divided by 405, which give you the HOMA IR level. So that is being checked nowadays to understand the insulin resistance. So I will skip all these slides. So I will understanding, as other experts will speak on this, maybe on Prameha Purva, but we see in most of the situations we do not find any clinical symptoms in prediabetes. If there are clinical features, you can definitely correlate it with the particular condition, or you may be correlating with the dosic aggravation, maybe kapha pradhana or kapha pitta pradhana or some slowness that is involved, or you may consider it to Prameha Purva. But sometimes these Prameha Purva lakshanas nowadays we are seeing in those patients who are already having over diabetes, be very high blood sugar level also. In some of the patients we do not find any of these Prameha Purva situations, but when we test them, because now it has become a practice among the public to have an annual checkup, an executive checkup, and they will come proudly with a set of papers to you, and they will see that it is mentioned that they are pre-diabetic. When I was studying DMS 3 decades ago, probably this concept was not there. Fasting blood sugar 120 milligram per day was considered as normal. Only PPPS has remained the same till now, 140, that didn't change. FBS 120 was normal, then 110 became normal, now 110 milligram per day has become normal. Now we have this separate set called as pre-diabetes. I do not comment on the any pharmaceutical industry lobby for this, but this has definitely helped the people regarding a warning sign that they may end up with the diabetes in future, especially if they are belong to a category of high risk. And insulin resistance, as I mentioned, is more important not only for diabetes but also for other conditions, like say PCOD for example, which can be very well managed. So it may be the role of kapha dosha, it may be the role of Agni, or it may be the role of Ama at various dhatu levels, or we have a long list of Prameha Purvarupas mentioned in various texts, which you may correlate to these pre-diabetic situations. which all of you know very well. Now, even if you are using some dietary advice, some exercise, some yoga, you may start some basic herbal therapy in prebiotic condition itself. Now, the question is why herbs? Before entering into a resolution, why herbs? Not according to Ayurveda alone, I am talking in terms of pharmacology. Huge research studies have been carried out on herbs across the globe. Always a student who is conducting a research in M.Pharm, they used to come to our college asking for that mention a few herbs which can be used in diabetes mellitus. And we want to study the pharmacodynamics and kinetics of those herbs. Now, what may be the reason for this? Why we are recommending them against the synthetic drug? Sir has mentioned metformin. So originally this drug was synthesized from the herb. And after identifying its structure, now they are synthesizing in the laboratory. So that may be the reason that we see even today, even after hundreds of years, it is the safest and most popular drug used in allopathy system. Now, what may be the reasons? Associated complications of synthetic drugs have led to a shift towards locating natural resources which have shown anti-diabetic activities. And of course, we have identified at least 800 plants in our classics which are known to have anti-diabetic activities. When the search was done with pharmacopoeia and non-pharmacopoeia drugs, means the drugs which are not mentioned in our Ayurvedic classics, about 1,200 plus plants were found to be having hypoglycemic activity, which is a very huge number. And further, when you see them, they are not just giving you the symptomatic relief or improvement in the glycemic level, but also they have found to improve other associated biochemical features and help to prevent secondary complications of diabetes, including dyslipidemia-like situations. And they have also proven to help in the regeneration of weaker cells of pancreas. So this is a very interesting observation. There are multiple plants, starting from the plant like Chilodarpas marsupium, Assam, even Meshashringi for that matter, which have shown an action to regenerate islets of pancreas. As Sir has mentioned, when fasting blood sugar is showing an increasing trend, already about half the mass of islets of pancreas have started getting damaged. Sometimes it is said that they are completely destroyed. We have seen the situations where with the help of Alexon in animal study, if you can destroy the islets of pancreas, they also can be regenerated with the help of these plants. So they have antioxidant activities. So the study says about 3.2 million deaths every year are attributed to complications of diabetes rather than the disease itself. And they may be common, uncommon or rare side effects. I am not going for the details now. And what are the modes of action that we can expect? When a search was done, about 13 different modes of action are observed for our herbs in treating diabetes. Not only one. So you may be having some allopathic drug which are having only one pharmacological activity by which we are reducing blood sugar. Or the drug like metformin may be having 2 to 3 different modes of action. But you have the plants which can have up to 13 different modes of action. And we are having polyherbal formulations or herbo-mineral formulations where multiple of these drugs are incorporated in our product. Drugs may be insulinomimetic, means which act like insulin, or they may be acting on insulin secreting beta cells, or drugs modifying the glucose utilization, or drugs showing adrenomyeliticism. They have a sympathetic activity. They act similar to epinephrine or epinephrine. That way they will help. And there are drugs, herbs, which act as pancreatic beta cell potassium channel blockers, because of which they will help in the influx and production of insulin. Then we have CAMP stimulators, which are the secondary messengers for insulin secretion. So we have renal glucose resorption inhibitors. We have herbal drugs which provide some necessary minerals, including the resorption resource. They also provide us these minerals, for example, calcium, zinc, magnesium, manganese, copper. They are present in a number of basma, lavana, like the kalpas. They are required for beta cells to produce insulin. We have drugs regenerating or repairing pancreatic beta cells. We have effectors of size, means ones which increase the mass of beta cells and also number of islets. Then we have glycogenesis and hepatic glycolysis stimulators. We have drugs that prevent the pathological conversion of starch to glucose by inhibiting beta-galactosidase, alpha-glycosidase and alpha-amylase. Then we have drugs which prevent oxidative stress. Most of our herbs are antioxidant, which is well known. So there are multiple modes of action. If I just go to 3-4 herbs here, you can see our bitter gourd or Karavellaka or fenugreek methicum, the most popular Madhunashini. So they are showing the actions by increasing insulin secretion, by enhancing glucose uptake, by adipose tissues, skeletal muscle tissues, which is usually seen in the case of insulin resistance, because these tissues are not in a position to uptake insulin properly. Then by inhibiting intestinal glucose absorption, now we have athermos-like drug which inhibits the glucose uptake from the intestine, and by inhibiting hepatic glucose production. So you can see these well-known, popular, simple herbs, they show multiple pharmacological actions. Some quick slides. So I have a long list of such herbs. For example, we have Bilwa there, we have Lashman. So we have Bhringaraja, Jambu, Guduchi, all this. So they are acting by regulating the glycolysis and also the Krebs cycle. Then, so we have the herbs which act by inhibiting glycogenesis. So like Bimbi, we have Mamachaka, we have Karavellaka, so we have Lavanga, we have Methika. So we have the plants which inhibit cholesterol synthesis, like vata. So we have plants that inhibit alpha-glucosidase activity, like Monas, we have Asana, we have well-known Sedation, which is more popular here in Kerala, Sathyanarayana or Ekanayaka. So we have the plants that inhibit glucose absorption. It's a long list. I will not go for all this. My purpose is just to show you that we have plants which can act by different pharmacological processes to improve the insulin resistance and also to control the glycemic level with other additional benefits. And we have products which have a combination of multiple of these drugs. Now we will go to the next part, which I wanted to highlight. That is resolution in pre-diabetic and also diabetic condition both. All of us are talking talking about these references since a long time, since decades. So I need not repeat them. What is the benefit? So I just would like to highlight on this one reference. The doshanam, naroganam, namumsam cha parikshanam, nadeshasya nakalasya karyam rasachikitsya. We have groups of people in Ayurveda itself. A few people, they are condemning that Rasaushadhi are not at all Aushadhi. Because the Shastra says that you don't have to go for any Roga Pariksha, Dosha Pariksha, Purusha Pariksha, and you can be Aushadhi. Some people say that this is a Prakshipta Shloka, but it's not like that. We have a reference for that. Even in Vaishnavism, that reference is there. Here the purpose of this reference is to just highlight the importance of this medicine in emergency. Suppose a patient enters to a clinic and collapses in front of you. He is coming for the first time. You don't know anything about the patient. And his BP is not recordable, his pulse is steady, so you may suspect some cardiac syncope. So something we have to do. You do not have the time to go for dosha pariksha, desha pariksha, kala pariksha, or all this. Take Trinetra rasa or Hemagarga protein, mix it with Ardak rasa, 1 or 2 drops of honey, and apply to the gums. Maybe 1 or 2 minutes, patient gets up. His EP becomes recordable, and now you can refer it or treat it whatever you do it. So that is what is highlighted here. You may not have the time to evaluate all these, but it is the resolution that comes to your rescue in such situation. That is why Sharadara says, Asadhyesh apidatavyaha rasotah shreshta uchate. You know that the condition is asadhya, but something you have to do, it is your responsibility, then it is the resolution that comes for your help. Couple of things you need always to remember when you give resolution. Samshodhya vidhina dhatu upadhatu vishanyati yojayat karmani prajnam dosha sanjayate anyatha. If you are not going for proper processing, maybe shodhana, not only shodhana, but also other processes. There is no shortcut method to prepare any resolution. If you follow that, if you stick to that, it will be safe and effective. Otherwise, dosha sanjayate, Shastra itself has clearly mentioned. Because we have many such incidences where area is observed. Acute toxicity is seen more in plants, less in minerals. You must remember that. Except for arsenics, rasadravyas do not give acute toxicity. Most of the other drugs may give chronic cumulative toxicity when you use them for a long period. If you do not know what is the dose, if you do not know what is the duration, if you do not know what is the anupama. So here, that point I want to highlight. Anupane rasa yujya desha kalanusarambhi doshakne matuna vapi kevalena dharina. Anupana is one of the extremely important factors when you give resolution in practice. We know that Anupana may be a targeted drug delivery system. Sometimes we call it as a vehicle in practice. Sekrate navatam sabada vidam vibhaktam pittam siddharya bhavana kavancha vata samuktam etc. eventually do it. Or you are getting rasnayak vata savidam prantimantam takulya rishna pittam etc. for yoga raja or swarna kasama akrata kasama. Everything at the end of the chapter, if you see in Rasnadarkan, you will find a long list of amalika prayoga. In all amalika prayoga, you will find various anupanas. But that is not the only role. Anupana can act as a bioavailability enhancer, and Anupana also act as a cytoprotective, which is most important for us. For example, you have Rasamadikya. A study was done by late Dr. Sathyanarayana sir. So when Rasamanitya was given with water in animal study, in chronic toxicity study, it had shown a few necrotic spots, especially in endometrium and also in liver. But when it was given along with Mathu and Ghृta, which is mentioned in the text classically, it did not show any toxic at histopathological level. So you should never neglect this. Our physicians usually neglect these two aspects. One is Anupana and second, Aushadha Sevana Karma. We are least bothered about that. We do not understand its importance. If you are sure about that, you need not worry about the safety. Okay. In Madhumeha, we have a long list. I will quickly give the names. We can categorize these formulations under Kalviya, Parvathy, Protani, Kuhupa, Pallava, and Basma preparations. Some of them can be used in pre-diabetic situations and some of them can be used when over-diabetes is observed. Here, practically, we are using Chandrakalarasa. Chandrakalarasa is mentioned in Rakta. It is also mentioned in Daha Adhikar. And in practice, always we think about some dysfunctional uterine bleeding whenever Chandrakalarasa name is there. Or sometimes in Daha, for example, in diabetic neuropathy, which is one of the very good drugs. So diabetic neuropathy, you know that there may be burning sensation, there may be paresthesia, or there may be pain. So different associations we use accordingly. Suppose if it is pain, you may go for Ekandivira like drugs. If it is paresthesia, you may be moving for Najeeb or other pupil containing drugs you can use. If it is Daha, you may be moving for Chandrakalarasa. But more than that, it is also useful in reducing blood sugar, not only for symptomatic improvement. A controlled clinical study has shown that it also helps to reduce the blood sugar, and not in a condition where the blood sugar is very high. Maybe at pre-diabetic or just above that. The particular product has been used, because I have seen only last week itself I had a patient who cannot be declared as a diabetic, but she already had the symptom like paresthesia, feet and mild burning sensation. So in such situation, you can definitely give Chandrakalarasa. You need not worry about that. Then we have many of the formulations because of the time constraint. I will skip them. And these are all variants of Vangeshwarasa, which can be practically utilized and market. Brihat Vangeshwara, Vangeshwara, both are available. The first one is Rasasiddha containing yoga. That is from Vaishnavi Ratnavali. Second one is from Yoga Ratnakara, which is having Ganga Basma. Chandraprabha is well known to all of us. Vasanta Pushmakara, it is mentioned in Prameha, also mentioned in Rasayana Vajikaranakara. Putra Prasava Karaka. So that is the indication of Vasanta Pushmakara. And of course, we use it in various conditions, including chronic myeloid leukemia, I use it. And of course, in Prameha, we use it. In Madhumeha also we use. Probably in a pre-diabetic situation, I am not very sure we are using it or not. But it can be indicated, especially when there is a familial tendency, where most important thing is an immunomodulator, which can help you to prevent the development of the disease in future. So Vasanta Tilaka is another Vasanta Kalpa. Then we have Apurva Malini Vasanta also, another Vasanta Kalpa that can be used. Here you can see number 21, Ananda Bhairava. So this is a reference mentioned in the Sathyanarayana, where he has mentioned in Jiyodbhuta Meha it is indicated. So probably it is indicated in chronic diabetes mellitus, so may not be in a pre-diabetic condition. I will speak them. Then under Parvathy Prakarana, so we have at least 5 different properties which are indicated at various stages of prameha, starting from pre-diabetic condition up to chronic diabetes mellitus. But we rarely use them in clinical practice for this purpose. When the name Parvathy, we always think about GI diseases, maybe Grahani. Vijaya Parvathy is specifically mentioned in prameha because it contains Maukli Bhasma and Vaikranta Bhasma, which are having very important role to play in prameha and its complications. Then Lauha Parvathy and Panchamrita Parvathy, Swarna Parvathy are also indicated in prameha prakara. The dose varies from 125 mg to 250 mg. Many times Kalpa Prayoga practically may not be possible, at least go for Samanya Prayoga. If the condition is like Grahani, you may have to go for a Kalpa Prayoga. So there are 2 very interesting properties here. For example, Bhuvaneshwara Parvathy, Sudha Parvathy. And this Parvathy is having Swarna, Rajata, Aparaka Bhasma as ingredients. And Sudha Parvathy is having only Sudha and also Shuddha Gandhaka. It is not having any mercury. And this particular product has got another interesting clinical indication, that is Yuvan Acne vulgaris. So you have to take 1 part of churna, lime powder, 2 parts of Shuddha Gandhaka, mix them and prepare a product. So that is having very interesting indication in pre-diabetic condition, and also it is mentioned in prameha pidaka when a person develops carbunculus. This is another indication. And pottery lohagarbha, karagarbha and tridhatagarbha pottery can be utilized. And under Rupa Kurasana, 2 of them have been evaluated, Swarnamanga and also Maharadhya. I will just show those publications for you for further reading. Lauha kalpas are more important in pre-diabetes because we know Lauha Bhasma and Madhura Bhasma, they are useful in dyslipidemia-like condition. So when there is an elevated triglyceride, increased LDL, decreased HDL, insulin resistance incidences are increasing. So in such situation, these Lauha kalpas are important. There is one product called as Triushana Vilauha, so which is already evaluated for its efficacy in diabetes mellitus. So Bhasma, there is a long list, so I will skip them and will just show you 1 or 2 studies. So these are a couple of tips given in a book called as Rasatantra Sarasika Prayoga Sangraha. Most of you must have read this book. So it is published in 2 volumes. So we have clinical tips. So there are 3 books which I usually recommend for practitioners. One is Chikitsa Pradipa, written by Dr. Bhaskar Vishnu Gokhaleji. Very interesting formulations are there. He himself developed some formulations using Kachari, Parvathy and Pottery. He incorporated some herbs and prepared his own products. And whatever he has written, all are based on his clinical observation. It was written in 1960s. Probably it is printed and available till now. It's a very interesting book. Rasatantra Sara, published by Karada, Ajmer. It also has got a number of formulations based on clinical experience and stage-wise how they can be utilized and how you can change them. Here, under Raupya Bhasma Prayoga, you will find a couple of references. First he says, you can take 1 rati of Raupya Bhasma, 1 rati of Aparaka Bhasma, mix them together and mix it with about say 2 ml, approximately half teaspoon of Ardha Rasa and also Madhu and administer. Another prayoga is same, Raupyavasma. So you have to give it with a very unique anupam. You have to take 1 tola of psyllium or isabgol and add 40 tolas or 40 times of milk and boil it to prepare a kheer, thick consistency. Use it as anupam and administer. So this is another prayoga. If it is not available, you can use santanika, that is a milk cream or butter, and he has given a duration of 22 days for administration. Another prayoga is you can give it with 4 rati of Shilajatu and Madhu. Then we have a couple of Avaleha Kalpanas. There will be differences of opinion regarding the use of honey in this stage. Pre-diabetes, it should be possible. The first one is Salasaradi Leha, which contains Lauvavasna and Tamravasna along with Salasaradi. The second is Vangavaleha, which is a combination of Vangavasna with Madhu. So both are mentioned in various stages of pranayama. One established drug in pre-diabetes, both with experimental study, that is animal study and pharmacological study, in vivo study, and also clinical studies, is Shuddha Shilajatu. We are using tons of Shilajatu in our products. But what about the availability? Whether it's available in that extent is always a question mark to us. It is a hugely adulterated substance. A petroleum product is added with hippuric acid so that it becomes gomutra, and it is sold, it becomes carcinogenic. That is the reason why United States FDA has banned it. It says that if Shilajatu is used, we are not responsible for that. So newspaper advertisements are seen. If you get Shilajatu Patthar, you will get the mineral. You can extract Shilajatu from that. You can be confident about that. But nowadays we have a couple of companies in India and also in Russia and Romania which selling Shilajatu, but it's very pricey. It's not for manufacturer. For a consumer it is okay. They will give it in a beautiful container with a silver spoon, and we can use it in a small quantity. But practically it is very, very difficult. Anyway, that is the other side of the story. And this is a study which shows that these are the various mechanisms by which Shilajatu is useful in insulin resistance. It improves insulin sensitivity, it has an antioxidant property, anti-inflammatory activity, it improves glucose metabolism. Animal studies have shown that it is almost equally effective to metformin when the study was done in Alexon-induced diabetic rats. And there was a clinical study where 500 mg video of Shilajatu was given for 3 months, which improved both fasting and post-meal blood sugar in type 2 diabetes mellitus. Dr. A.B. Trivedi and others have published an animal study data. Some was talking about the concurrent use of allopathic drug and Ayurvedic drug. So you need to be very, very careful regarding the herb-drug interaction, especially when the interaction is happening at metabolism level. When we are talking about ADME interactions, at absorption level you can predict, you can avoid it, but at metabolism level we do not know when the interaction is happening. But as Sir has said, 2 hours will be a safe period. But these 2 drugs which are mentioned here, glyclamide and metformin, both of them are having a synergetic interaction with Ayurvedic drug. And this is of course Shilajatu with Gymnema, Meshashringi. Meshashringi has got a synergetic interaction with both glyclamide and metformin because their bioavailability is increased. So you can definitely reduce the dose of metformin whenever you give any product which contains Gymnema, that is established. We have a couple of articles published available to you. So many studies are done on herb drug interaction in anti-diabetic drugs and also anti-epileptic drugs. It's extremely dangerous in anti-epileptic drugs. Suppose Tagara, if you are taking, Tagara has got an interaction with electron, it may precipitate epilepsy. So these are some things which need to be studied further. There is one report already published under pharmacovigilance by Dr. Urmila Thatte, one patient who was diabetic, whose blood sugar was well controlled with allopathic drug, including insulin. So she was prescribed with a formulation by an Ayurvedic practitioner for psoriasis. And that patient reported at a stage of unconsciousness, and finally he succumbed to death. He had given a formulation which is containing Dikkalasandravya Pradhana, which is common in Kushta and also in diabetes. And he did not evaluate the dose of anti-diabetic that he was taking. So we have a lot of things to discuss on this. Anyway, so let me skip these slides quickly. This is another formulation which is evaluated under Asaushadhi, that is Chaturmukha Rasa. And here they gave Chaturmukha Rasa along with Trifala Kashaya, and they took the markers like alpha amylase inhibitase, then in vitro salivary amylase inhibitase, and in vitro alpha glucosidase inhibitase to find out the effect of the drug, and it was found to be very useful in animal study. Vasanta Kusumata Rasa, we are having a very interesting study where it helped to prevent the diabetic retinopathy. So that is a study published by Sathyanarayana and others. Another formulation study is Tarakeshwara Rasa, and this formulation was used in microalbuminuria associated with the diabetes mellitus. They give 125 mg of Tarakeshwara Rasa with 3 grams of Udupara Falachuna, and it had given very good result in preventing these diabetic nephropathy possibilities. So Chandrakala I have already mentioned, I will skip them. Another formulation study was Lakhumanini Vasanta. Role of Lakhumanini Vasanta in management of type 2 diabetes mellitus. These are all over diabetes, not pre-diabetic condition. So I can definitely skip them. But it's a good study. In 56 patients they have studied it. Under Kupka Parasana, we have a study on the Swarnamanga, effect of Swarnamanga on Madhumaya. This is an animal study. We have another study clinically carried out. And this is an interesting study. 2 samples of Makarandhvaja were studied. Makarandhvaja was prepared by using Swarna 1 cup, that is thin foil of gold. In another group, Makarandhvaja was prepared by using Swarna Bhasma. They compared it both clinically and also in animal study to show which sample is better. So they found that Makarandhvaja prepared by using Swarna 1 cup, gold foil, as mentioned in the classics, was found to be having better efficacy both in animals and also in clinical study. Among Bhasmas, we have studies on Nagamasa, multiple studies. Then on Vangamasa, we have studies. At least 4 studies on Nagamasa, 2 of them clinical studies. Then on Vangamasa, we have studies. And Vangamasa, there is 2 interesting studies. I cannot show you all the details. So one study is Vangamasa was prepared by 2 methods, mainly for Shastra people. One is, there is a method called as Vastrapata, which is not followed in this region. It is usually used in Gujarat. So there they take Shuddhavanga, then they add cloth, a huge amount of waste cloth they add. They light it with tusha. And gradually, slowly this cloth burns, gives a low heat for a prolonged period, and the tin oxide is produced. it is white. We will get Shweta Vangalasma. In market, you will never find Shweta Vangalasma. It will be again greenish or grey color. Another method was they went for regular Jaran method and Basma was prepared. So that was a comparative study. Another study was in the text you will find to prepare Vangalasma you can go for Ardha Gajapura, mentioning Rasakasma. So they prepared Vangalasma by using Ardha Gajapura and compared them. In both the studies, they compared the sample for their anti-diabetic activity. And that was both a clinical study and also animal study because it was the part of thesis work. And in these stages, they have observed that the product which was prepared by following the classical Charan method was more efficacious. By following Gajapata method was more efficacious. Studies are there on Yashoda Basma also. And studies are there on the combination of Shilajatu and Vanga Basma, Shilajatu and Yashoda Basma. And on Abraka Basma. Abraka Basma has been found to have an activity to regenerate islets of pancreas. This is my last point. So we have been using the product in our institution, which is so as this is a commercial product, I am not going for the details of this product. So this is one of the products which has got a US patent. So we are having 17 US patents. This is a product which already has a United States patent sanction. So we have evaluated this product for its safety by using the OECD 423, 407, 408, 452 guidelines. OECD 423 as you know acute toxicity guideline, 407 is subacute and 408 subchronic and 452 chronic toxicity guideline. Then we have evaluated in vivo study and it was found to have a pancreatic cell regeneration activity in alexol-induced diabetes mellitus model. And one young field study and one PhD studies are carried out on this. And we have seen that it improves fasting blood sugar level by 40% and HbA1c by 30%. So in my practice, I am using only 4 drugs. One is as a single drug I use at very first level. If you are considering it as a pre-diabetes along with yoga, meditation and dietary guideline, I use a single drug like Vishashruti and the next one is Jambu. So depending upon other associated biochemical parameters like say dyslipidemia, Jambu will help more. And if we suspect insulin resistance, Vishashruti will help more. So I use it. And in the next stage, I may be using Asananda Kashaya. Next stage, I may be using my own drug, our own drug insulin. And when there is an over diabetes, if we see that patient is resistant to this regular medication, I usually add Asananda. Now it has become very expensive, not affordable to the patient. We use it along with Amalaki Children, which will definitely help the patient to get very good clinical improvement. So with this, let me conclude today's presentation. When you see all these Rasoshatis, majority of them do have Nagavasana, Vangalasana and Kajaya, or Nagavasana, Vangalasana and Rasasangva. It is the Nagavasana which is of concern. In the study that is conducted, Shashtiputa Nagavasana was effectively used with all the safety protocol. So if you are able to prepare it properly with lead sulfide as the final product, it doesn't cause any abnormality. Otherwise, it is possible that it can cause neurotoxicity, more than hepatotoxicity, neurotoxicity is more dangerous. And also, when you prepare it, there are two methods commonly followed. One is using Parada as a medium, another one using Manashila as a medium. Study says that when you use Parada as a medium, it is more safe and more effective. And this long list of research which I have shown, only if you are in use, many are not practically being used, and you need to undertake more safety studies and efficacy studies and use them practically in various stages of diabetes. If you are sure about the GCP, GLP, GMP and establish quality and safety, automatically we say that efficacy is also ensured. Thank you for your patience.
Thank you so much, sir, for this very informative session. If there is any queries, I request everybody to write it down and hand it over to the volunteers. Now, we'll be moving towards the discussion session. May I now request the moderator, Dr. Ramya ma'am, to discuss the queries put forward by the audience.
Very good morning to everyone. So, first of all, I take this opportunity to thank all of our respected speakers for this informative session. And as Dr. Sathyanarayana sir has to lead, we will be discussing the questions which is addressed by Dr. Sathyanarayana. First question is, yesterday one of our professor told that many of the Ayurvedic medications is having hypoglycemic effect. But you are now in the presentation, you are delivered like there are 1,200 plants which is having hypoglycemic effect. How does it works?
Of course, this is based on a survey which is reported, already published, which includes pharmacopoeia and extra pharmacopoeia herbs. Pharmacopoeia herbs means those which are documented in our classes and also in the published pharmacopoeia. And non-pharmacopoeia are those which are not documented officially or we do not know in our textbooks. So, but many of them, they are reported in one or the other studies as having hypoglycemic activity. But all of them have not been completely evaluated regarding the mode of action. Mode of action, I have already mentioned, there are 13 different possible modes of action, which is already tested based on the study conducted around approximately 800 herbs.
Thank you, sir. The next question. What is the long-term safety profile of medical-based resorption in chronic diseases like diabetes, especially in patients with diabetic nephropathy?
So diabetic nephropathy, I have already shown one study where they have evaluated where associated in diabetic nephropathy, microalbuminuria, effect on microalbuminuria is tested. However, it is important for us to monitor the patient regularly, especially monthly basis for renal function test and also urine. So based on which you will be aware regarding the status of the renal function and also the albumin that is getting excreted in the urine. As Sir has mentioned in his presentation already, more than microalbuminuria, it is the hematuria and other types of inflammatory changes happening in the kidney are more important. We have the products which contain shilajit. So we have the products, let's say for example Shiva Butika. We have the products like Vasanta Usmanta Rasa, which have proven to be very, very effective in preventing nephropathy and also in treating diabetic nephropathy. We have seen that in Vasmas. So we have Vanga Vasana, which is very useful in managing this particular condition. Another one is the Yashoda Vasana. So these two Vasmas are already evaluated for nephroprotective activity and also in managing the diabetic nephropathy.
As a physician, how will you differentiate the normal and fake shilajit?
As a physician, it is not so easy except for the classical test. What you can do is the classical test mentioned in Rasaraka Samachaya. You know that Salileya Pavilayam, or when you put in fire it becomes Lingavat. Only these tests are available for us, but that is very difficult. It is not so easy. We will have to find out only the established, authorized vendor. Suppose if it is Basma, we have at least some NBS test like test in which you can try, but definitely when you follow some classical tests that are mentioned, especially in the Samachaya, to some extent you can confirm that it is Shilajit, but I cannot say that it is 100% established because you will have to go for even HPLC also sometimes to establish the concentration of fulvic acid. Uric acid is cheap drug, anybody can add it, but fulvic acid estimation becomes more important. Practically it may be difficult for a common practitioner, but please get the certified Shilajit samples. There are well-known vendors who will give a proper certification with all the values to you. It is slight expense.
Sir, can long-term administration of Tava, especially Tava has role in pancreatic beta cell regeneration by treating the cardiac pitta?
We do not have any established report to this. We can predict that it is possible because there are two important actions of Tamravasana, as you know very well. One is Medohara and Lekhana, and second one is the Pitta Virechana. So these are the two important actions that we observe. That is how it acts on various conditions related with the liver. So we will have to establish, some of you can take a study on this, because a study is done on non-alcoholic fatty liver already. So probably it is possible for us that many of the pathological conditions have got a close association between pancreas and also hepatic function. And when we see the mode of action of drug like Shilajit, Vangavasana and Yashodavasana, so we have seen that they are having a very similar activity in improving the regeneration of islets of pancreas. And in Abrakavasana, we have seen that the total mass of islets is increased. So we can just have a prediction. We cannot have a certain answer as we do not have an established report.
Thank you, sir, for your valuable outputs. Next, I would like to hand over the session to the commenting team for further proceedings.
Thank you so much, sir. And ma'am, with great respect and heartfelt gratitude, I invite our distinguished speaker, Dr. Sathyanarayana, sir, to kindly come forward and receive memento as a token of our profound admiration and gratitude. May I request Dr. Sri Vidya ma'am, Professor and HOD of Department She holds an MS postgraduate diploma in mental health and international credential in substance use disorders. She has also completed a fellowship in epidemiology and biostatistics from University of New South Wales, Australia. With over 8 years of teaching experience and more than 20 research publications in India's journal, her area of interest includes women's health, neuroendocrinology, and integrative public health. Today, she will be speaking on management of insulin resistance in women, protective hormone, fertility, and future health. Please join me in welcoming Dr. Parvathy Unnikrishnan.
Good morning, all. Am I audible? Most respected faculties on the dais and the most respected faculties of the dais, and my dear budding researchers over here. Thanks for that warm introduction. So let me just move on to the topic directly. Before itself, I would like to tell sir that just remind me, I have got a manual with regard to this microphone. So if I am going overboard, just tell me regarding the time. Okay, so I just want to acknowledge that there is a slight change in this particular topic. My focus is going to be just women. So this presentation is going to be for all beautiful ladies here. So let me just start. So as I was acknowledging, the topic is being reconsidered to women. What is the reason? So I'll be just going through in a quick glance towards what is the reason why I landed up in this particular topic. So the truth itself is, all human body is itself set in a stage as insulin resistant. That is the fact. So it's not a biologically wrong incident when we are placed as insulin resistant prone. It's a kind of an evolution. It's a kind of a mechanism, or it's all about an adaptive mechanism which our brain decided past, so that there is a trend of going into insulin resistance for the human body per se. So it's not going to be a metabolic error. So initially we are going to just check what is the kind of the discrimination between that physiology and pathology when insulin resistance is concerned. So that's why initially we just try to understand what is the physiology of insulin resistance, what I was trying to explain. So it's all about, you can just rethink and reimagine. When we got injured, what is going to happen? It's all like our brain will sense that injury and all the glucose will be pumped to that particular area of injured cell so that it is getting healed. So what is going to happen in terms of growth phase? So all the glucose should go, all the glucose should pump towards the growth plate so that an effective growth is happening. And what is happening during lactation, my topic. So during lactation, and glucose is being pumped to that particular priority organ. So this is the physiological aspect of insulin resistance, where there is an adaptive kind of mechanism. This is nowhere going to be a pathology. So what is going to happen? I mean, what had happened? So as I was telling, there was a concept called stronger. What does that stronger means? Stronger means we had a time period where everybody's focus was towards muscle. Like we had to run, we had to go for hunting. So muscle was the most important thing that we considered in the past. So that is the stronger concept. Okay. Then coming to the smarter concepts. Nowadays we are in that smarter concept. What is that smarter? The stronger is transformed into a smarter setup wherein the muscle is not given priority. What is given priority? Can anyone just try to guess what is the priority nowadays? Please tell me. I want interaction, please. Even if it is wrong, no problem. We all are going to learn together something. I mean, it's all about brain. What is this one? It's all about brain. So we don't worry about the muscle or the strong concept nowadays. We just worry about the brain. We want the cognition. We want that social intelligence. We want that emotional intelligence. We want that planning capacity, right? Do you agree with me?
Yes.
Yes. So that stronger is transformed to a smarter setup. So regarding this particular aspect where stronger is changed to smarter, insulin resistance is physiology. There is an adaptive mechanism wherein the body is trying to pump glucose to the brain so that the neuronal cells are active. There is nowhere there is a chance of neuronal inflammation. The neuronal cells are well and active. To that point, everything is fine. But do you think, are we satisfied with this? Are we listening to our brain or our pancreas or the liver? Are we? I'm asking you, beautiful ladies, are we listening to our inner voice? Please say loudly. No. So, again, the brain is helping us in terms of stronger to smarter, right? But for females, what is happening? We have got another protective layer as an estrogen. Have you heard about estrogen? Everybody is well aware about estrogen. There is a well-established protective mechanism from estrogen, especially the 17-beta estradiol, which is the most biological form of estrogen what we see during our reproductive life. So we have got the protection of estrogen. We have got the protection of estrogen from ovary, and we have got the protection of our brain as an adaptive kind of mechanism wherein the glucose is pumped into our brain and estrogen is supporting brain. Estrogen is definitely, you might have known that you might have understood that estrogen has got a very important kind of anti-neuroinflammatory effect. So that's why we don't get Alzheimer's during reproductive age. We don't get that kind of mood disorders. There are very less chance of getting into mood disorders during the reproductive period. Why? Because there is a protective layer of estrogen. There is a protective layer of 17-beta estradiol for females. Are we satisfied with this estrogen? Are we satisfied with this estrogen? No, we have got two layers of support now. One is our brain. The second one is our ovary, which is giving us 17-beta estradiol. Still, we are not satisfied. Are we satisfied? Say no. We are not satisfied. Okay. So what is going to happen? So what I mean to say is, estrogen is acting as a buffer. So what is the meaning of buffer? What is the meaning of buffer and the difference between a That's what the estrogen will try to buffer the entire system of a female, that please be calm. I can make sure that the reproductive system or the entire system for this female is going to be okay. So that's the difference between a buffer system and a force point system. Estrogen is just a buffer. It is not going to even give a command to the entire body. It's going to just give a word that please wait. At least at this point of time, you be calm and don't give more glucose, so that the beta cell is not going to get exhausted as much. Like there is always a compensated hyperinsulinemia from the body. No, to take care of the entire activities or to take care of the entire metabolism. So if estrogen is giving an order, or if estrogen is requesting the liver that I will be taking care of the entire system of this particular lady, means if we are satisfied, we would be definitely happy that 100% I would be happy that no PCOS. Am I stating it clear? So if the buffer system from the estradiol, it would have been considered as a command, where estrogen is telling liver that you should do like this. You should stop secreting glucose. In that particular case, no PCO, no menstrual abnormalities, no endocrine abnormalities, no insulin resistance for female at least, because of the protective layer of estrogen. But estrogen is just acting as a buffer. Am I making sense? So, what is going to happen? We are not satisfied. We are not satisfied with these two protective layers, what we have. Again, we are on constant stress. Chronic stress, sedentary life, calorie abundance, sleep disruption. So the entire, I would just like to remind you that the entire active kind of insulin resistance is for those ladies who are not depending upon 24/7 buffet access. And who are not listening to our sleep dietary practices, advices, or sleep hygiene practices. For those who are strictly following the diet practice or the lifestyle modifications and the sleep hygiene practices we advise, for them, these adaptive kind of insulin resistance is definitely going to help them during their reproductive age. But we all are not satisfied. Look at me. I'm not satisfied. Okay, so I'm not satisfied either. So we need to think about all these scenarios to handle a case of probable insulin resistance or a probable pre-diabetic state to go for a reproductive cycle treatment. That's my point. Okay. So, what is going to happen if I am chronically stressed? If my visceral adiposity is going high, and there are a pumping mechanism from the inflammatory adipokines like leptin. Leptin is an important one where we need to take care of. And ultra-processed diets, as Sir was telling about the significance of getting into an ultra-processed diet. So this is why I am going to talk about why this topic matters for me. So as a person from Sri Yoga, and definitely as a person who is interested in mental health, this is what is going to be my focus for today's presentation. Increasing precocious puberty case. Everybody is well aware about precocious puberty cases, right? So what are they going to do? No, they don't know what is going to happen in terms of precocious puberty. Definitely genetic influence is there, but other than the genetic predisposition, what are the external kind of independent factors which are contributing to precocious puberty? And rising menstrual disorders, androgen-related disorders, as hyperandrogenic conditions like acne vulgaris, and hirsutism cases are rising like anything, and we don't know what is to be done. And increasing PCO cases. The next one is the most important one: midlife fatigue. What is the specialty of midlife fatigue? It's again, we don't have that second layer of covering. We don't have that protective covering for midlife fatigue. Why? Because she is in a phase of perimenopause. cardio access. So that is also important in terms of midlife fatigue. So in spite of all the normal lab values, she is suffering something. Even we will be asking her what is happening. You just tell me what is happening. Then in that particular case, sometimes the patient is getting so much aggressive and she will not be able to tell you what is happening. Right? So that's the kind of a peculiar kind of clinical presentation, especially what we know during midlife crisis. And definitely there is another component, when everybody will be thinking about in terms of oligomenorrhea and amenorrhea, especially in case of obesity, insulin resistance. But there is a very dangerous condition wherein there is a hemo instability which we will be able to see in AUB cases. That's again can be seen as a complication of the unopposed estrogen in case of PCO. And metabolic dysfunction, and definitely as sir was telling, we need to take care about GDM, gestational diabetes mellitus, and why GDM is important, we will be seeing it in the coming slides. So just by this slide, you might have understood that it's not always uterus which is going to decide the fate of our entire treatment strategy. Some other organs, brain is going to decide something, ovary is going to decide something, most importantly, pancreas is going to decide something, liver is going to decide something. Why? Because your command from estrogen should be, get into liver. Then only you will be able to see all these effects, right? So we expect all these organs to come up together so that we will be able to deal with all these conditions. So this is a nutshell, this is from a paper. So from this slide we will be able to get what is happening for a lean lady and an obese lady, and we are not so sure that a lean lady is without any insulin resistance. That is also the most important thing. So for that we need to go for some surrogate markers to understand what is the possibility of insulin resistance for that lean lady. So now I would request you to just scan this QR code. This is a very simple activity that together we will try to learn something. It's just a 5 minutes activity. So you may please take your phone and just scan that QR code. Sorry. So I hope the QR code is done. Shall I move forward? How many yes and how many no, please? So are you able to see some question there? So these are some random questions where we try to understand what is our understanding related to the women and the insulin resistance and the whole scenario of reproductive system. So are you able to see in your device these questions? Yes or no, please? Yes. Okay. So just give an answer. For all these, some 5 to 6 questions are there. So I will read out for you those who are not able to do it. When you hear insulin resistance in women, what is the first word that comes to your mind? I already got an answer from Madam, the obesity. Okay. So not doing it. No, I don't know what is happening. Actually, I should see the responses within the slide. I can understand that many are responding, like 16 or 160 responded. But unfortunately, I am not able to see it. So, can anybody just, no, I will, as Madam told, it is obesity for her. Maybe some other words? PCOS, then somebody was telling diabetes, if I am not wrong. Some diabetes. Is there any option to? Acanthosis is very good. It's very good to see acanthosis as an answer. Then PCOS. Anything else? Okay, so these are just the words that is coming to you. Obesity, to just tabulate it. Obesity, PCOS, acanthosis, and hirsutism, okay. Then I can add acne. Any other kind of interesting words? Say for example, I get a word cardiac arrest. So something like that. Is there any word which will be coming to your mind as a complication? As India being considered as, specifically Kerala being considered as the capital for all the kind of metabolic diseases, we should expect those complications, right? First, if you ask me, I would definitely go for a word which is tabulated under the complications of a metabolic syndrome, right? So we'll go to the next question. Thanks. So these are the answers from your end. Central obesity, GDM, diabetes and PCOD, diabetes, infertility, fibroid, recurrent UTI, diet pattern, nephropathy, weight gain, infertility, acne, central obesity, hirsutism. Okay, so many things. So we'll go to the next. Which organ may show dysfunction early in insulin resistance in women even before the glucose rise? That's very important. Even sir was telling about going for mental health and all, right? So my primary area is neuro. Okay. So I would always go with a kind of explanation related to brain. Okay, I'll tell you why I am considering brain as a kind of initial organ where it will try to give you some symptoms. So now answers to brain are coming. So I'm very happy that somebody is coming along with me, is getting aligned with my thought. So why I'm telling you this, a girl, just imagine an adolescent girl is telling you, so if you are repeatedly telling her that learn something, study something, your board exams are about to come. So you learn something, learn something, learn something. What is the answer that you can expect from that adolescent girl? Definitely, first line of response is going to be a defense. Right? Now you cannot expect 90%. You cannot expect 90% of students coming in. Yes, mama. I am good to learn. You cannot expect such a kind of response from an adolescent girl. So first response would be the mild response can be wait a month. Just 5 minutes. 5 minutes. That's a mild response. So ranging from the moderate to severe, what can be the response? Just imagine what is the severe response or the kind of aggressive response that you can expect. Please. We all are facing that kind of response each day, right? So just tell me, what is the kind of aggressiveness that you may receive from your child if she is an adolescent? Mild response. Oh, so that's again a passive kind of response. I want an active, aggressive kind of response.
She will throw the book and
She will try to throw it away the books. Right? And again, she may walk from there and going to shut the door. So these are the kind of aggressive possibilities from an adolescent girl. So these definitely there is a component where it can be because of the parenting itself. But my perspective is totally based on the biological kind of thought process where her response can be totally based on a thyroid dysfunction. Right? So she may be lazy. From an external perspective, she is not going to learn, she is always sleeping. That kind of laziness will not be understood in a proper manner by us. Being parents, being doctors we may consider, but being parents, we always consider it as a negligence. Okay, so but in that particular scenario, we need to consider whether there is any thyroid dysfunction. Again, it has got a relationship with insulin resistance. Okay, so coming to a perimenopausal lady, she may always tell you that, no, I am getting craving for something, to eat something, right? And she is getting these mood swings that repeatedly she'll be telling that I am anxious, I am depressed, I am not able to take care of myself, nobody is going to listen to me, even my child doesn't listen, my husband, my spouse is not ready to listen. So all these factors or all these kind of explanations what we get from a perimenopausal lady, it's not about the uterine clinical symptoms. It's not about ovarian clinical presentation. It's about the HPA axis, wherein there is a parallel axis which is running along with the HPO axis that is all related to the hypothalamic pituitary and adrenal axis, where stress is going to regulate everything. Okay, so that's my point here, and we'll move to the next question. What symptom do women most commonly report before metabolic diagnosis? Before a metabolic syndrome diagnosis, what is the most possible symptom that a woman mostly commonly reports? Tiredness, definitely, fatigue, obesity, weakness, overweight. So now what do you think? What is this all about, this fatigue? Why you are feeling that fatigue, laziness? dizziness. What is it all about? Which tissue is which tissue is deprived of glucose? Which tissue is deprived of glucose? If you see it in a general sense, which tissue is deprived of glucose in that particular case? So do you agree with me now? So there is a brain fog. That's another symptom which most of the patients used to tell. And we'll go to the next question. Can a woman with normal BMI have insulin resistance? Definitely, you'll be telling it as yes. So, heavy menstrual bleeding is primarily the options I can read out: structural uterine issue, hormonal imbalance, and metabolic dysfunction, stress related, combination of all the above. So that's a very easy question. Right? Combination of all the above. Can chronic stress alone worsen insulin resistance? Most important thing. I would say this is going to be most important point throughout my lecture. Can chronic stress alone worsen insulin resistance? Yes. If insulin resistance during pregnancy remains untreated, who is affected? Who is going to get affected? Okay, both. Which is harder to treat insulin resistance? That's a kind of a tricky question. Which is harder to treat in insulin resistance? Well, nobody is going to for that blood sugar. That's the most important thing, right? Sir is going to blame me. Being an endocrinologist, he is going to blame me. Why you are not focusing about blood sugar? So my question is, which is harder to treat? Which is harder to treat? We all are doctors, so which component is going to be the most hard part to treat? Stress. What about emotional eating? Stress and emotional eating. Agree on? How many yes for that? Somebody is telling, if stress is removed, you will be able to get a response in terms of emotional eating. How many yes for that statement? 50%. 50%. So what about sleep deprivation? Again, if stress is removed, you will get good sleep. No, bidirectional pattern. If stress is removed, the other one is also getting removed. Okay, so I don't know what is the answer. So this is the end of our presentation. We'll go back to our lecture. Okay, so in spite of all these things, what we shared just now, there is a rule of this insulin resistance. My point is regarding adaptive kind of insulin resistance, where it's not a basic pathology to explain. So there is a rule. What is the rule? Especially when it comes to female, the body or the brain will try to assess what is the priority. What is the primary priority to be dealt with? That's the first point. Okay. Is that an acute injury? For example, after CS, after cesarean delivery, there is an injury. Right? Even if you go back to our Ayurveda classes, it's a Shunya Sharira, which is being considered for Sudika. Right? There is no ojas, there is a tremendous Dhatu in the form of a Shithila Dhatu for a postpartum need. So, body is going to prioritize, is there an injury? So, in that come to the injured site for healing. Then body is going to see whether she is an adolescent girl or she is in Tanner's 2 or Tanner's 3. What is Tanner's 2 or 3? Which indicates her pubertal status. Tanner's staging will give us an idea related to the puberty, staging of puberty. So, growth, whether she is in her growth phase. The next is whether she is lactating, whether the demand for Sthanavritti is there or not. The point related to Garbhavati and Swavritti is done. So now it's all about Sthanavritti, which I will have to take care of. Then pregnancy. Okay, so based on these prioritization, the body will try to, or the brain has got a capacity to understand where it needs to be pumped, and that's not going to create any issue. But we are not satisfied either. By all these things, we are not satisfied. We are chronically stressed. We do have a nutritional overload as calorie overload and ultra processed foods, and we are not satisfied. So then, there is no prioritization as such. Physiologically, in our body, where there is no satisfaction at all, there is no prioritization, and what is going to happen? All these kind of glucose or all these kind of things are going to get pumped into the adipose tissue. That's the reason why we are getting into a phase of visceral adiposity, especially during perimenopausal phase, especially during the pre-pubertal stage. Right? There is no compensatory mechanism or there is no adaptive mechanism here in this particular case. Based on the priority, the body will decide. So as in this particular scenario, there is no priority physiologically. So what the body is going to do? The entire priority is being given to adipose tissue. What is the specialty of adipose tissue? What is specialty of fat? Fat holds the major area as in an endocrine organ, right? So the major area is held by fat. So it's easy for the body to prioritize it to adipose tissue. That is being loaded as visceral adipose tissue. That is the most unhealthy part when as far as insulin resistance for a female is concerned. So then it's coming as a systemic disorder. So at the point where the body recognizes that there is no priority physiologically, everything is pumped into adipose tissue, then it is a difficult situation to handle. All these organs are going to get affected, especially for females, starting from brain, adrenal gland, ovary, uterus, adipose tissue. Everything is going to get affected in terms of the discrepancies related to insulin signaling. So we know associated with the insulin growth signaling, IGF, insulin-like growth factor. There is a reduction of SHBG, which is very important for the reproductive axis, sex hormone binding globulin, which is the most important thing which we need for whole entire reproductive axis to be active. Okay, so these pathways are going to get disrupted. Brain first, so that's my point, not sugar first. So based on the questions, at least now you might have understood, based on the clinical presentation at least. Brain is the primary organ, especially for women, we need to handle the brain first. Okay, so for a long-standing solution I'm telling, we need to handle the brain first. Then the neuronal signaling is going to be okay. And why brain? I will tell you the reason. What is the importance of brain here? This is the importance. Stress and cortisol integration. Don't just try to misinterpret stress as a kind of external stress always. It's not always an external stress or an external predisposing factor which is causing the stress. The stress can be a part of a low-grade inflammation. Can be a part of an innate low-grade inflammation like a Bija avastha. There is no predisposing factor. And internal low-grade chronic inflammation can cause this stress. So what is going to happen to that stress? And once she is chronically stressed, it's a low-grade inflammation proceeding, postpartum phase. It's a low-grade inflammation. So we need to take care of that postpartum phase by doing Sulika Virginia. Garbhini, pregnancy state. It's again a low-grade inflammation state. So we need to take care of it by using Garbhini Virginia. Okay. So chronic stress always will try to signal the HPA axis, which is the simultaneous axis in terms of female working as parallel to the HPO axis. So one difference is HPO is hypothalamic pituitary ovarian axis, simultaneous HPA axis is working as in a turbulent manner. So the cortisol is highly activated. What is the importance of cortisol? It's the awakening hormone. That is the speciality of cortisol. She will not be able to sleep. So that's the importance, that's the beauty of our system. That we will be able to understand once a patient is coming a simple clinical presentation. As in, we will be able to understand the insulin signaling in brain. There is some problem. There is a brain insulin resistance which had happened. So in that particular case, we will be able to do something so that this particular axis at least will not work. This integrated psycho-neuroendocrine loop, we need to cut that axis. So this is again an important point wherein we need to consider an obese and lean. So it's always a paradox to talk about obese PCOS and lean PCOS, isn't it? There is a paradox existing with it. So obese PCOS, we do have a notion that obese PCO coming to our OP, definitely she is insulin resistant. Is that so? We need to go for surrogate markers. At least we will be checking BMI. But BMI is not going to be an apt marker in case of a lean individual, right? So in that particular case, what we do in our OP practice, BMI definitely will be going and checking. But again, we will be using waist hip ratio as a fat anthropometric matter to assess what is the kind of biometric evaluation for those patients. Additionally, we do have some, for our case at least, if she is coming with oligomenorrhea or amenorrhea with the PCO pattern, PCO phenotype, as sir was telling, lean PCO phenotype is called as toffee, or thin outside and fat inside. Okay, thin outside and fat inside, that is a typical phenotype of lean PCO. So in that particular case, again we need to go for this biometric evaluation and some biochemical evaluation. For in our case, she is presenting with amenorrhea with some hyperandrogenic symptoms. Definitely we will be referring her for free testosterone value, SHBG value. So then we will be able to understand the possibility of going into a metabolic syndrome or the insulin resistance or prediction of the next metabolic syndrome. So coming into ovary, ovary is not going to be the primary organ, definitely. Once all these organs start giving signals to our body, ovary will try to understand, yes, there is some problem, there is some issue. So I need to take care of this. So it all starts from estrogen, right? So where do we get the maximum estrogen in our body? It's gonads. But again, there is an extragonadal steroidogenesis. Extragonadal steroidogenesis from adrenal gland. There is a potential secretion of sex corticoids. It's not a biologically active form of estradiol what we expect from adrenal gland. It's the male version of hormone. It's the male version of estrogen what we get from adrenal gland. That is the cause for the hyperandrogenesis. Okay, so again, these axes will come together and the patient will be coming and telling you there is acne, there is acanthosis, there is hirsutism, there is alopecia, right? Are you able to recollect all these symptoms? So then it has got a relationship with your liver and insulin resistance. Ultimately, the end organ wherein we are going to discuss is uterus. But we always, as gynecologists, we always try to perceive it in terms of uterus. As a body, I mean, as a patient is coming, for us, always uterus is going to be that body, right? And to a maximum, we can go and refer to ovary. So ovary and uterus are going to be our concern as a specialist from gynecology, not brain or the other organs. So this is why it's important. There is always a life cycle expression, especially when it comes to feeding. Starting from, I should say that it should start from birth. Do you agree? It should start from birth and it should continue to generations for a female. Right? It should start from her birth and it should continue towards the puberty. It should continue towards the reproductive cycle, continuing towards pregnancy, towards postpartum, towards perimenopause, towards menopause, to the next generation. So there is an intergenerational life expression what we will be able to see, especially in case of insulin resistance. So these are the kind of clinical presentations that we will be able to
understand in terms of life cycle expression. So if she is an adolescent girl, as I was telling, brain will try to signal you with regard to some clinical presentations. And we will have to see all these things to understand. We will have to understand all these organs and all these clinical presentations pertaining to each of these life cycles. So as you can see, menopause, it's quite interesting to see that there is a different fat redistribution. Those who are going into the perimenopausal phase will be able to understand. It's not a gradual transition from the reproductive to the non-reproductive phase, isn't it? It's not a gradual phase. It's a kind of an abrupt phase. It's a kind of an abrupt phase wherein the body will not be able to adjust, and that's why she is not able to communicate with us properly. So these are the kind of the markers what we will be considering in terms of precocious puberty. That itself is an early expression of insulin resistance. We will be noticing increased amount of leptin, which is from the adipocytes. So this is a fetal programming model. So once a pregnant lady with GDM is presented, what you should expect? I remember in the shloka from Garbhini, down to the explanation, there is an explanation from Acharya that if she is consuming more Madhura Pradhana Dravya, what's going to happen? There is a programming model within our shloka. The fetus is going to suffer from prameha. That's a programming model from our own Acharya giving description for the Garbhini, Pajari and the Dauda explanation. So then the same thing is explained as the programming model, and everybody is well aware about the Barker's hypothesis. Are you able to understand what is Barker's? It's all about the fetal origin of adult disease. The seed of the disease was planted somewhere during the fetal period, and the disease, when it is going to manifest it as a remote outcome. Maybe during her adult life she is going to experience it. That is explained as Barker's hypothesis. So this was the point. There is an intergenerational metabolic flow. So this is an appetite program which is being told as Madhura Ahara Pradhana Dravya by Garbhini. Within the fetus, within the womb itself, the fetus is programmed for appetite. So what is going to happen? Leptin will increase. Are we satisfied with this? Are we satisfied with this? This can be considered as an adaptive mechanism, but we are not satisfied. The children are exposed to lace. Children are exposed to so many things, so many endocrine disruptors, bisphenol, so many endocrine disruptors, even air pollution. So then that is going to happen. That's going to hamper the adaptive mechanism of insulin resistance, and it is moving to a maladaptive insulin resistance. Definitely there are long-term risks as well. So these are the environmental drivers of insulin resistance. Most importantly, the endocrine disruptors like plastics, bisphenol, which is a component in all the plastic bottles, air pollution, gut microbiome. That's where we will be able to do something. Gut microbiome and sleep. Okay. So this is an interesting kind of pendulum which I got from a research article. Early life stress is there, that we know. There is a GDM, there is a chronic stress. But what can be done? There is a possibility wherein there is a possibility of resilience, or there is a possibility of vulnerability, and there is a possibility of trajectories. So what does that mean? This paper says that if she is exposed to some kind of stress, if she is avoiding the lifestyle changes which created that particular change, definitely she is going to feel that resilience. Again, if she is consuming all those kind of things, there is a phase of trajectory as in maladaptation. This is interesting, right? So there is a place where we will be able to enter. So that's my point. We as Ayurveda physicians will be able to enter based on this particular pendulum. There is a genetic disposition as an early life stress, but we will be able to do something. So entire stuff was being interpreted as an adharana. Definitely it's an adharana in the initial stage as an upavasta, and there is a meda obstruction. At the level of megodharma there is an obstruction as in samana samsaya, and definitely there is an apada vata fluctuation, especially in case of gynec disorders, and
there is a Rasadhatu Dushti which we will be able to see, there is a Rektadhatu Dushti we will be able to see, there is a Meghodhatu Dushti we will be able to see, there is a Pitta, Kapha, Avarana. It's again relative. There can be Kapha more within that Kapha Pitta, or there can be Pitta more. So all these conditions we are going to tabulate within all the menstrual abnormalities, all the sleep disturbances, all the weight insulin resistance cases. So what is going to be done for the management model? As in, it's going to be highly personal, and I mean we always try to understand a personalized kind of approach from Ayurveda. So we need to consider sometimes it's just Avarana, it's more towards Kapha, and we'll have to focus upon Agni, regulation, and stress modulation. That's my focus point. And Garbhini, even if an antenatal care or a Garbhini is coming to your OPD, consider counseling practice. So I would recommend, considering your busy schedule within the OPD, I personally, what I felt is, within each and every kind of OPD, there should be a counseling kind of OPD, which is adjacent to that, for all the cases. I mean, it's not a joke. You will feel the real difference once you try to intervene with the counseling practice. But still, that stigma exists. Okay, try to underline that. That stigma within Kerala, especially, that exists with regard to counseling. Once we say a patient that, okay, this is referred to counseling OPD. So what is the existing stigma? I don't have an issue. Then why are you referring me to counseling OPD? So that's the kind of a stigma which exists in Kerala. But what we do is, I would try to translate, or I would try to name that particular counseling as behavioral therapy or motivational enhancement. So that's the most important thing, especially in case of lifestyle modifications, what we do, as Sir was telling. So it's not going to be enough for a patient that we will be just telling that these kind of lifestyle advices you do. There is no motivation for that. So again, you need a counseling expert for motivating them. So that's motivational enhancement. Sorry sir, just to conclude. So the entire lecture was all about protecting the metabolism, protecting the hormones per se, HPO and the HPA, protect mind, and we are going to protect the generations based on the pendulum of vulnerability and protection. So insulin resistance in women, it's not a number on a lab report for me. At least in our cases, we will be definitely going for surrogate markers for assessing the condition, or maybe predicting the possibility of metabolic syndrome, or what extent it can proceed. That will be done, but definitely our treatment is not going to get decided upon those numbers. So it's her appetite, her stress, her cycle, her fertility, and her age. Thank you for your patience.
A huge gratitude to Dr. Parvathy Unnikrishnan for this session. For your expertise have made the topic come alive. If there is any queries, I request everybody to write it down and hand it over to the volunteers. Now, we'll be moving towards discussion session. May I request the moderator, Dr. Anna, to discuss the queries and put forward by the audience.
Thank you, Dr. Anupama, for the powerful and impactful presentation. Welcome back to the discussion session. So we have a few queries from the delegates, but as we have time constraints, we are not able to discuss all the questions. So we will discuss the important ones. I will read it for you, sir. Will early and prolonged use of metformin cause dependency?
No, never. Metformin, unlike other addictive drugs, no addiction with metformin. Actually, once we stop the metformin, patient symptoms will reappear. Actually, like polyuria, hyperglycemia effects will reappear. Then patients are only take that with the metformin. No dependency. It's actually the disease is increasing. Actually, the disease is progressing when you stop the metformin. All the research studies, nothing related to addiction. You can say they use and stop. One more thing, once started, the patient always asking the question, once you started, you cannot stop. No, nothing like that. You can discontinue the metformin safely in a safety manner as the disease is properly cured with lifestyle modification. Especially in the diabetes, you can stop the metformin in a safety manner. There is no more different.
Thank you, sir. Next question. In chronic diabetes cases, sometimes only PPBS is found to be elevated, even though FPBS is in normal limits. What may be the reason?
It's the usual scenario. Most of the patients is always advised to do FPS. Fasting sugar and sugar PPBS is mandatory for all the diabetic patients. Most of the patients used to do only fasting blood sugar. So we need both PPBS and FPS because it's, the fasting is normal and PPBS is on the higher side. It suggests that the patient is having glucose impaired glucose tolerance. That is something that very good glucose tolerance because the positively glucose surge is there. So it will be immediately tackled with that one. Insulin release should be there. Insulin sensitivity is there. That tolerance is impaired. That means we need to do for these medications, we need to for insulin, etc. The PPBS is high. It's better to go for insulin. Insulin will be high because that only immediately lower post-prandial glucose. That indirectly tells you that immediate glucose insulin release is not possible in your body. That's when the glucose spikes happens in surgery, immediate release of insulin is not possible. In your body, insulin is having some resistance in there, so better to go for insulin high PPBS level normal fasting. Thank you.
Thank you, sir. We don't have any questions for Unnikrishnan. So, Parvathy, okay. Is there any questions? Okay, with this, we formally conclude the discussion session. Now we are moving to the concluding session. So I respectfully invite Dr. G. Vinodkumar sir for their concluding remarks.
We had three excellent presentations here. Dr. Najeeb pretty much elaborated the pathophysiology of the diabetes mellitus and its management. Even the last question I wasn't informing. Its possibilities are elaborated by him very well. When he talked about this pathophysiology, I just remember about the Charagava disease, Kapasavita, Pavarasta Dosha, Medosra Sukha, Sita, Manjara, Soja, Pishibandha, Pushya, Prameha. It is very important we correlate with what he said, these verses of Charagava and our other. Serving beta cells are very important. That is one of the core points. And lipotoxicity is a major another cause he highlighted. Family history also describes beta cells reserve loss. That is a very important point he put forward. So, earlier onset of obesity, reduced physical activity also. We know the diagnosis of last year, so the suppressed vulnerability is very much provided with what he said here. High refined carbohydrate diet. So, the importance of diet, he elaborated here very well. When we say about rogas is ahara sambhavam vastu, rogas ahara sambhava, hidahaka viharacha visheshas pradukayo. That is all area of the ahara is very important for yoga and aroga also. It is very much described by and the importance of vyayama also very much important given by Ayurveda. And the management also be very well established here. Early intervention, weight reduction, and the exercise also he gave very how to do exercise. 150 minutes per week. That also be related. This exercise along with metformin. When we say all the metformin or all the diabetic drugs, they are specifically indicated that with exercise it is more effective. All the medicines it is and modest weight loss will be and he says it is not, we are not getting immediate effect within 1 month or 2 months. A 12-month span is very important. That's a very important point here. activity, food, and stress management is also key. And the pre-diabetes diagnostic criteria very well established here. And just fasting sugar or PPF is not enough to assess the diabetes severe. And HbA1c importance is described very well here. And having metabolic risk also. And atherosclerosis progression, which leads to another diseases like cardiac diseases and cerebrovascular accidents, etc. also. It was a very good session. I am not going to in detail because of time. It was a very informative, very effective session by Doctor. Congratulations, Doctor. Thank you very much.
Thank you, sir.
And the clinical experience by Dr. Sathyanarayana, he elaborated. He is also saying 1,200 herbs are there which have metabolism effect. And in this, so many studies he showed here, described in detail about what's in different span of diabetes. Different was drugs in different span of diabetes also he described. And resolution importance by Sathyanarayana, and that is also different. Acute toxicity less in the surgery, he stated here, more in plants. That is also one point. So I congratulate him also in his absence. And Anupana is very important. That is one point we should follow. When Acharya described a specific Anupana, or something to mix with that. If we give with that particular anubhana or mixing thing, then only we get the desired effect or the effect described by the others. That's the one main point he and another point he highlighted here is the Aushadaka. Normally, most of us, some of the people are not consider this aspect. We have to do in our any practice, this Aushadakala is also very important. And according to condition and symptoms, the different drugs also give highlighted here. And the importance of Shilajit and the marketing strategy of Shilajit causes adverse effect also be highlighted. Okay. Dr. Parvathy, Unnikrishnan, you all already had a very vibrant session by her. I am not commenting on much on her session because she came to your heart by her presentation and she altered her management in Ayurvedic perspective to implement. And all things I am not going to. The body is designed to become insulin resistant. That is one of our very important statements. That is to be insulin, growth, lactation, and pregnancy. And she described how it happens. And one very important point is former to smarter. And that described muscle brain-based strategy. Energy priority shifted to brain priority. Very, very thoughtful comments these are. And estrogen protection and protection decline of menopause also she described here as well. Midlife fatigue and maybe pre-menopause also she noted. Lifestyle expression and management. Anurkarana, Aktivana, plus management is very important. She highlighted counseling, brain center. These are all points we described very well. Actually, it was a good subject for us by three eminent speakers. I congratulate once again for on behalf of all of you. Very interesting session. I take this opportunity to my hearty thanks to all the participants for their patient hearing and active participation in that. On behalf of the moderator and the chair, I express our sincere thanks to all of us. I take this opportunity to give my sincere thanks to the organizers of this seminar for giving me a chance to preside this session. Thank you.
Now I hand over the session to the co-bearing team for further proceedings.
Thank you so much, ma'am. Thank you so much, sir. With great respect and heartfelt gratitude, I invite our distinguished speaker, Dr. Najeeb, sir, to kindly come forward and receive memento as token of our admiration. For which, I request Dr. Seena ma'am, HOD, Department of Panchakarma, to kindly present the memento. Thank you, sir. Thank you, ma'am. With great respect and gratitude, I invite Dr. Parvathy Unnikrishnan ma'am to kindly come forward and receive memento as a token of our admiration. May I request Dr. Seena ma'am, HOD, Department of Panchakarma, to kindly present the memento. Thank you, ma'am. Thank you, sir. Now, I request Dr. Vinodkumar sir to come forward to receive the certificate as a token of gratitude, for which I request Dr. Seena ma'am, HOD, Department of Panchakarma, to kindly present the Thank you so much, ma'am. Thank you, sir. Now I request Dr. Ramya ma'am to come forward to receive the certificate as a token of gratitude from Dr. Seena ma'am, HOD, Department of Panchakarma.
Thank you, ma'am. Respected dignitaries and honored delegates, now we are heading to the non-competitive presentation session by faculties and researchers of Prepared National Seminar 2026. This session brings together insightful academic contributions from our respected faculty members and researchers who will be sharing their scholarly work into experiences and research perspectives related to premature insulin resistance and associated metabolic disorders. Let us now begin with the first presentation titled Principles and Practice of Premesha Chikitsa in Ayurveda, a critical analysis of the current scenario. I invite Dr. Abhilash sir, Assistant Professor, Department of Kriya Sharira, to present this work.
Good afternoon. Topic: Principles and Practice of Prediabetes and Insulin. The critical analysis on the current scenario. It has been done taking the concepts and practices together and to analyze what is there in the current practices. And is there a connectivity between the principles and practice? So, first of all, naturally for taking this topic, the reason for that and treating the many times we treat the cases, but the principles will not be the same. It will be applying something, but the actual happenings will be different. So to highlight those areas, and there are some concepts which lack that in Ayurveda we were discussing last day also. Then integrating the modern concepts, how to integrate and how not to integrate. So that's the crucial area because using our modern concepts, intuition skill because of how to everybody Ayurveda but also integrated medicine. And then the most importantly, the evidences and research areas. So this is the area, this is time where we have to integrate these concepts into research and practice. So if we are not doing this now, then we will not be able to do further in the future. So the objectives were there are some variations and concepts also in the practices. So to identify those variations and the strategies and the rationale for the practices and the some modern correlations with the biology concepts and all. And hence accordingly how we can update our principles. So the basic concepts are Osha, source, layer, and most importantly, all of them are connected through gunas. Gunas connect all these concepts together. And practices, then we have seen the Stula and Krishna Chikitsa, and the Guru-Vishna therapies, Pitta Kapashana Chikitsa, Leda Shoshana Chikitsa, and preventive aspects, the side of things. These are the common practices going on. So the strategies taken by these practitioners are generally pre-diabetes reversal is possible control and how we can reverse this pre-diabetes, how we can implement diet and lifestyle plans, and protection of solving others. We have seen ST is not commonly affected in diabetes. This has something with solving others only. So how can we protect those solving others? And when we are using this medicine as an add-on therapy, how effectively we can use those add-on therapies. So those how can we different needs of Shodha. And then complication of management like Shanagya or Shanagya managing complications mainly. And finally the precision medicine. How can we precisely diagnose and treat those conditions? So these are the strategies currently employed by the practitioners. So these therapies or these strategies are basically the Kapatika Shavana is based upon the Leda Shoshana and they are connected. And if we practice some diets and lifestyle, they will be Legu and Ruksha in their connector. I don't know that there should be synergism with the modern medicine. And if the design is done, Dhatu National product is the key concept. So this one is the pathophysiological basis as identified from the practices. So generally all diseases begin with Kalimadia and it will be affecting either Koshta or Srodus and it will be generating Amma, mostly upper predominant. But there are two variations. This first one is when this instead of Shila, Shila is dominating means it is generating Veda and it is Pitta Kapha dominant. And third one, if the Legu and Ruksha is dominating, it will be leading to Dhanushaya and it is a Vada dominant. So it is applicable to all the diseases and accordingly we can classify diseases into three categories. Disease, Jora, Nasa, Shwasa as the Kapha dominant conditions and Rasta is the seat of these conditions and there is a suppressed state of Pitta. So this condition is predominantly managed by management of Amma. And second cluster of diseases like Prameha, Kushta, Vidrati, etc. They are having primarily Pitta as the dosha and the Rektidavi is the seat of these conditions. So there is a suppressed state of Vada. Second dosha is Kapha. So Vada is in a suppressed state. So the managing Kapha and Pitta is mainly advocated there. And third spectrum, including Pandu Vada, where Vada is having a dominant role, Pitta, Arjuna, Kapha is in a suppressed state. Here also Pitta is the most common side. So this classification can include all the diseases mentioned in the Samhitas. So how to handle them? And there are some knowledge gaps like role of is not the Vasti therapy, the Vasti Sthana in the pathogenesis of these conditions is pramena. Because generally we see osmotic diuresis happening in diabetes. It is a sign of it is not a beginning of not a sign of pathogenesis. It is a representation only. It is a result of all these increased sugar level in the body only. And this Vedavahana, a function of Kodra, when the body has more waste materials, urine will be containing those materials and the urine will be having this increased level of sugar also. This generally urine is medium of urine is used to remove the waste products, particularly acidic waste products. So all these mainly more acidic materials in the body, the urine will be containing those acidic materials. And regarding Pragul Veda, we have seen yesterday also, Snigdhamsha is generally referred to as Pragul Veda. So I think generally there is no need to mention it as Veda because it is already Snigdhamsha is mentioned there. Sneha, activities of Sneha already mentioned in the Samhitas. So in a legal perspective, there is no need to mention it as a Pragul Veda. And regarding the use of exercises, particularly vigorous exercises, it is not recommended. Generally, even Samhitas tell that hard exercises are needed. Generally, general principle is that you should not begin hard exercises directly. Padanshila pranama should be followed. So it is generally causing more harm than benefits. So this one is the modern pathogenesis. The combined role of liver, adipocytes, pancreas, intestine, and muscle tissue in the pathogenesis. And the insulin signaling pathways, different pathways we can identify all the pathways like inflammatory markers, cortisol. They are connected to this development of insulin resistance. So anywhere in this pathway, problems will be there, and sometimes multiple issues will be there. So which one is the most important? That is the problem to identify in a clinical practice in dealing with every disease. So the connection with the stress will be more common, or sometimes the connection with the inflammatory markers will be more severe. So that is very much important. So organs, which organs are concerned, lipids and proteins, how they are metabolized in the body, inflammatory free radicals, how they are managed by the body, and stress and cortisol, how they are managed by the body. And considering all these, we can plan the reversal mechanism. So that is the common thing done in the practices. So while adopting an evidence-based approach, there should be some precision regarding the identification of data. We should be able to identify where it is, how serious it is, and we should be able to identify the links leading to insulin sensitivity and resistance. On one hand, there is sensitivity, and it is affected insulin resistance. So how far we can improve the sensitivity and how far we can prevent resistance. Considering all the leads together, we can adopt some plans. And analyze their impact in the body, and how to achieve glycemic control and how to prevent complications. These are the two models behind the practice of Ayurvedic management in diabetes and Prediabetes also. So for that purpose, personalized approach can be adopted since we have seen the conditions where Pitta Kapha is playing a major role in pathogenesis. So according to Prediabetes of individual, we can plan medications and preventive protocols in different conditions. So that's all.
Thank you so much, sir, for that insightful and informative presentation. Moving on to the next presentation, the topic is consolidation of findings on diabetes related research work done at GADC in
there. A very good afternoon to one and all. And first of all, I want to thank Department of Kriya Sharira for giving me this opportunity to present a small portion of my research work here. And also all the PhD scholars who have already completed their works and submitted here. So directly go to my topic. Consolidation of findings from diabetes-related research works done at Government Ayurvedic College, Tripura. So, a total of 28 studies are available in our library regarding diabetes, prediabetes, etc. So, we can divide all these studies under two categories. The first category belongs to prediabetes and diabetes and comorbidities of diabetes. And second category includes the diabetic complications like neuropathy, retinopathy, ulcer, and nephropathy. And today I am going to deal only with the first category. So going to the first subheading, prediabetes. Only 3 studies are available here. All the 3 are interventional studies. The first one, the effect of selected yoga techniques in glycemic control among prediabetic cases. So a total of 45 minutes of selected yoga techniques were applied in this study. Going to the results, only FPS and PPS values were assessed, and after the treatment, there was clinical and statistical significance for decrease in FPS and PPS, but the decrease was not consistent in the follow-up period. The next one is the effect of Parvathy larger pair in prediabetes. In this study, medicated pair paired with Buddha and Parvathy tumor was applied for the patients. And according to the results, all the objective parameters, including the diabetes, PPS, FPS, and lipid profile, HbA1c values, shown clinical and significant decrease. medical trials available here. The effect of Armenides Parasapada and the Chuna in patients with diabetes in India. Only NPL values was assessed and all the values were found to be significant. Next two are the procedures done in diabetic patients. First one is done in diabetic patients. It was a comparative clinical trial. A comparative clinical trial to evaluate the effect of glandular withdrawal of conventional tooth extraction in diabetes patients. The first group was extracted by the procedure glandular withdrawal, and second group local anesthesia and followed by antibiotics. There was not that much difference in pain, bleeding and healing, but only during the extraction the pain was that much increased in the first group. And next one is role of Veda Dharma. It was a prospective observational study. The role of Veda Dharma in manifestation of popular pathological findings and on diabetic patients, a prospective observational study. 108 patients were included in the study, and the symptoms like watering of eyes, redness of eyes, and discharge from the eyes and swelling of eyes are found to be significantly associated with the Veda Dharma. So going to the conclusion. So in these all results indicates that there was so much effectiveness in Ayurvedic treatment in the diabetes and also prediabetes cases also. But there are so much database of skill process that can be filled by further researchers only. And as scholars of Ayurveda, beyond the research work or publications, our responsibility to translate research findings to public awareness also. And evidence can only be generated by researchers only. And as scholars of Ayurveda, we have to strengthen this foundation. And thank you for patient hearing and listening.
Thank you, Doctor, for presenting such comprehensive and meaningful business outcome. Moving on, our next presentation is on the role of endocrine disruptors in prediabetes. This presentation sheds light on environmental and biochemical factors influencing metabolic imbalance. For that, I would like to invite Dr. Najeeb, Assistant Professor, Department of Agriculture, for the next presentation.
Good afternoon all. I am directly going to my topic, role of endocrine disruptors in prediabetes. These are my contents: introduction, endocrine disruptors, prediabetes, factors causing prediabetes, and loose picture concept. Coming to the introduction, we all know that endocrine disruptors are chemicals or compounds that interfere with hormone synthesis, secretion, metabolism, or excretion. And increased exposure to these endocrine disruptors will lead to insulin resistance, which in turn results in prediabetes. And endocrine disruptors are mainly present in knowingly or unknowingly via exposure into the daily using substances like washes, conditioners, sunscreens, clothing, plastics, etc. And mainly BPA, that is bisphenol A and phthalates are the mostly widely used substances that we are coming to contact or exposure. And BPA is considered as most widely used synthetic product worldwide, and its production reaches over 10 million per year, and the production of phthalates reaches about 8 million per year. And this endocrine disruptor phthalate is used in drug cosmetics, toys, paints and clothes, etc. And coming to the prediabetes, we all know that it is entered in the medical literature in 1980, and prediabetes is diagnosed based upon the impaired fasting glucose, impaired glucose tolerance, and HbA1c. A, and it will bind to the one estrogen receptors present in the liver, and which in turn impairs the insulin secreted and increases the gluconeogenesis, which in turn results in hyperglycemia. And the phthalates can result in the alteration in the hormone metabolism, that is particularly affecting the peroxisome of proliferating activated receptors and increased fat storage and altered glucose metabolism in the layer, and it may promote the insulin resistance and resulting in the prediabetes. And changes in the glucose transport expression, that is GLUT. And dioxin, this is a organic pollutant, persistent organic pollutant, and it will affect the glucose transport activity in adipose tissue, pancreas and brain, and which in turn results in hypertriglyceridemia and early atherosclerosis and loss of beta cell function, which in turn results in prediabetes and diabetes. And disruption of the receptor expression, that is polypeptide glycemic (PCBs), will result in the decrease in insulin receptor expression on the cell surfaces and impairing the body's ability to respond to insulin and leading to insulin resistance. And the factors, generally we can classify the factors as environmental factors and genetic factors, and these endocrine disruptors will come in under the environmental factors, and other side it will lead to overweight or obesity, unhealthy diet, and physical inactivity and psychosocial stress. And we can consider this we can correlate this endocrine disruptors with Ganavisha, that is Alpavidia. Alpavidia vishas are considered as Ganavisha. In turn, this continuous exposure of these Alpavidia vishas will lead to cumulative toxicity in the body, that is Tushi Visha. Tushi Visha will affect what? Dhatu Prabhava Vigara, that is Dhatu Prabhava Vigara, Medorushti is there. It is mentioned in the Dhatu Prabhava Vigara, Medorushti, what is the Nidale, Pramehana, Purva Vivadi Anija. So, it results in the manifestation of diabetes. So, we can conclude that these endocrine disruptors play a major role in developing the insulin resistance in our body in the present scenario. So, we can adopt the principles of Ganavisha and Tushi-Visha in managing this prediabetes. Okay, thank you.
Thank you so much, ma'am. Now we move to another presentation. The topic is severe arterial claudication of lower extremity, peripheral arterial occlusion diseases associated with type 2 DM management through Ayurveda. I invite Dr. D-M-2, Associate Professor, Department of Shalyatantra, to share their clinical experiences.
Respected faculties and deans, my topic of presentation is severe arterial claudication of lower extremity peripheral arterial occlusive disease associated with type 2 diabetes mellitus, managed through Ayurveda. My presentation is introduction to medical research and conclusion. Introduction. Lower extremity peripheral arterial disease in type 2 diabetes mellitus is a common cardiovascular complication with atherosclerosis, plaque formation, narrowing of lower extremity arteries. This mainly affects the arteria, popliteal and infrapopliteal artery segments. Atherosclerosis occurs as an arterial disease in diabetes. Atherosclerosis occurs as an arterial disease in diabetes, and frequency of ambulation, higher revascularization is not attained. The prevalence of PAD in people with diabetes is pain for last 6 months, and she also complains of mild leg pain during even rest for last 2 months. History of listening complaint. The patient is a non-case of type 2 diabetes mellitus, schizophrenia, and hypertension, and under oral medication for these conditions. 2.5 years ago, we noticed that leg pain in calf region only. Just during walking time, while walking long distance only, the pain subsides afterwards. Gradually, the severity of leg pain increased because of able walk even short distance without pain and pain body at the first time at the rate of admission on 23 October 2025. Then history of present complaints. We had a history of cerebrovascular accident 1.5 years ago, and also we had a history of type 2 diabetes mellitus, schizophrenia, and hypertension. This condition, constantly condition is diagnosed 1.5 years ago at the time of cerebrovascular accident. Then, personal history. His diet is mixed, powerful, regular, appetite, nutrition, normal, and sleep was sound at the time of admission. But he has two addictions, smoking and alcohol. And two addictions he stopped just before admission when his was first diagnosed. Then, examination conducted on 23rd October 2025 showed his findings. His peripheral artery consists arterial, tibial, posterior tibial, and dorsal venous pulsations were feeble, unaffected left to lower limb, and his pulsations were normal on the right side. Then investigation. Arterial Doppler study of this patient was done on 9th October 2025, just before admission. Impression of that arterial Doppler study showed stenosis in common femoral and proximal, superficial femoral artery, causing distal absent flow signals and low volume monophasic non-intake arteries. The investigations done on 23rd October 2025 showed slightly elevated FBS level, PPS, total cholesterol, SUT, CVD, total lipoprotein count, ESR, hemoglobin levels are almost normal at the time of admission. HbA1c level is 6.4. Then diagnosis. Peripheral artery obviously disease of left lower limb in type 2 diabetes mellitus patient has a vascular complication. Kind of treatment for this patient is internal medication to increase vascularity of leg, cerebrovaginal to improve arterial flow, and we found out rather strongest result. Indian medications. Indian medications include Vinodkumar G, Najeeb, and dose 2 times per day. Then addition to you might be with Kashaya, you might be the sound. These medications started from the day of admission to the day of discharge. Half teaspoon PD was given to this patient from fluid normal 2025 to the day of discharge. Another medication given for the medication was Ayurveda. Ayurveda was Vinodkumar G. This medicine started from the day of admission and was 5 mg and continued to 7 January 2026 at the day of discharge.
Respected dignitaries, faculties, and delegates, good afternoon to all. First of all, I would like to thank the organizing team for giving me an opportunity to present a paper on this subject. And we are going to the presentation. The topic is insulin resistance, the pathophysiological bridge between Scalia and Pramea. I will start the presentation with the research study. The result of this study demonstrated first and second degree obesity, which causes a 4-time increase in risk of diabetes. This is a retrospective cohort study which is conducted in USA in adolescent population, where they have observed the progression of obesity to the incident diabetes. So in this, they have found out some interesting fact. The reduction of weight of 4 BMI from obesity to overweight significantly reduces the risk of developing diabetes mellitus up to 50%. Suppose if a person is overweight, compared to an obese person, he is having 50% lesser risk of developing diabetes mellitus. So there is a clear unseen significant gap which exists between overweight and obese persons. Now coming to the clinical observations in obesity. Technically, we are defining obesity and classifying obesity based on body mass index. But it cannot completely satisfy the whole pathophysiological
factor behind the progression of obesity to diabetes. So we have to include some metabolic profiles along with BMI. So based on this thing, we can classify the common phenotypes like this: lean healthy, lean unhealthy, obese healthy, and obese unhealthy person. So unhealthy phenotypes are basically of two types: lean unhealthy and obese unhealthy. Lean unhealthy means the person is externally lean, which means the BMI corresponds to the lean constitution, but internally the metabolic profile is unhealthy. But in the second condition, obese and unhealthy, externally and internally the person is obese, where BMI is high, and at the same time the metabolic profile is also moderate. Now, what are factors decide and explain? The main points include high visceral adipose tissue, first point. Second one, ectopic fat depositions, and third one is insulin resistance. So, high visceral adipose tissue is classically explained as the main reason behind the development of obesity to diabetes. Now, coming to the what adiposity means with respect to Scoulia. Adipose tissues are basically of two types: subcutaneous adipose tissues and visceral adipose tissues. And if the energy is surplus in the body, it can increase both SAT and PAT, which means subcutaneous levels of adipose tissue, and at the same time visceral fat also can get accumulated in the body. But even though the distribution of subcutaneous adipose tissue is more in the body, there are lesser chances of metabolic risk whenever SAT is high. But on the contrary, what is happening? High visceral adipose tissue always leads to metabolic errors, which further progress to metabolic dysfunction, including insulin resistance. Why this happens? Because subcutaneous adipose tissues are having more range of proliferation and differentiation capacity. But visceral adipose tissues are having, compared to SAT, visceral adipose tissues are having lesser rate of proliferation and differentiation capacity. This is the reason why visceral adipose tissues are more leading to metabolic complications. Now coming to the understanding of Vedodhatu in normal and abnormal phenotypes. How we can understand Vedodhatu in normal and abnormal individuals. High energy fertility, which is mentioned as Sandarpana, definitely leads to it. It can progress in two ways. First way is high subcutaneous adipose tissue and low visceral adipose tissue. So this actually creates a normal healthy status in a person, which is mentioned as Bartha. So here the metabolism of fat is normally happening in the body, and it will not progress to any dysfunction or any further disease. But the second possibility is actually high visceral adipose tissue. Whenever the visceral adipose tissue is more in the body, it will never proliferate or it will never differentiate. The cell size itself becomes enlarged, and it further leads to dysfunction of leukocytes. This is actually happening whenever the amount of visceral adipose tissue is more in the body. So let's discuss what is the progress happens in this condition. Hypertrophy of adipocytes. Whenever visceral adipose tissue is high, it leads to hypertrophy of adipocytes, which we call it as Prediabetes. And in the next phase, what will happen? Whenever adipocytes are hypertrophic, size is already enlarged. In the next phase, it causes dysfunction to that adipocytes. The cell becomes dysfunctional, and here it forms the samprati, which is related to Dhatu, which is explained in Sathyanarayana. So here, whenever Vedodhatu is happening, then Vedodhatu is not a normal process, it is Mushti itself. But in that stage, Vedodhatu Mandya is happening. What actually Dhatu is doing? Dhatu is actually helping in the proper metabolic process. Every metabolism is controlled through chemical mediators. What these mediators are doing, the same function is doing by the Dhatu also. So here, whenever Vedodhatu Mandya is happening, as a result of Dhatu Mandya, everywhere there is a formation of Ama, inside Koshta, inside Dhatu also. So Dhatu Ama is actually forming as a result of Dhatu Mandya. So in Scoulia, what is happening? Whenever Vedodhatu Mandya is occurring, it leads to the formation of an improper converted metabolic substance. Proper metabolism is properly not happening, it leads to improper conversion, and it will lead to the formation of improperly converted metabolic substance. So here in this what is happening, whenever the lipids or visceral fats gets oxidized, it leads to the formation of free fatty acids. This is getting released to the bloodstream, and along with that, at the same time, tissue cytokines are also getting released, which is the reason behind the low-grade systemic. Persistent low-grade systemic inflammation is created because of this release of Vedava's Srodha is literally happening. Vedava's Srodha is getting affected and Vedas is vitiating. Dhatu Vedas is vitiating in this stage. And the next phase, this cytokines and free fatty acid. Free fatty acid start to deposit over the ectopic site, which is mentioned as ectopicity in obesity. And this deposition happens in different sites, different other sites. And this at this point actually insulin resistance start to develop. So basically insulin resistance start in the adipocyte level, and the next level wherever free fatty acids are releasing, this fatty acids start to accumulate over the liver and the skeletal muscles, and there it start to produce portal insulin resistance. So at the same time, two mechanisms are happening: systemic insulin resistance and hepatic or portal insulin resistance. So in this point, what is actually happening? In the first level, in the adipose tissue level, whenever insulin resistance is there, that was confined to Medodushti. But at the next phase, it is actually including other dhatus also. This mechanism actually progressing from one tissue level to the other tissue levels. So here it makes the change from the Samratyos Saulya to Prameha. In Saulya, it is explained only related to the Medodhatu and Medodhas sources. But whenever it goes external to the other tissue levels, the involvement of other doshyas happens. And this is the stage where actually Saulya is progressing to Prameha. So this is simply explained in modern as systemic insulin resistance. So that is Dhamana which is created. Wherever see Dhatu is actually a complication or a part which is part of this process or Prati, and with this Dhatu it creates Avarana over different tissue cells. Whenever it is confined to first Sthana, we call it as obesity or Saulya, but when this progress to another tissue levels or multiple tissues, it progresses to Prameha. So this thing is same thing is explained here: insulin resistance at multiple levels progresses from Dhatus Saulya to Prameha because of the involvement of other dhatus also. Now I am trying to explain Kriya in prediabetes. Actually, prediabetes is not it's a subclinical condition, but I am taking the symptoms as lecturers and trying to explain the Kriya of prediabetes based on the previously explained Samrakta. So first phase in every Kriya phase 1 is Sanjaya, because here Kapha and Vedorati is happening in Sanjaya phase. The second phase, Pragopa is there. Kapha Pragopa is happening in Vedas, which leads to low-grade systemic inflammation. The definition of Pragopa is actually explained as Vilena Hypertrophy. So whenever Vilena is happening, there should be an association of Ushna Guna. That is why Kapha Pragopa is usually happening along with the Ushna Guna Samsarana. So here Pragopa is happening in Vedas, and it causes or it produces elongated systemic inflammation at that level. Third is Prasara, which is actually adipocytes are oxidized and it started to produce free fatty acids, and this production and release of cytokines into the circulation forms the Prasara avastha, which is the third phase, and in the fourth phase, somewhere else it is getting deposited. So that is actually Stana Samshraya. So this deposition over the unwanted site of the ectopic site make the Stana Samshraya. In this phase actually Purvarupas are mentioned. When we consider prediabetes as Prameha Purvarupa, we can explain Prameha Purvarupa under this fourth stage of Kriya. But even though it is subclinical, there are certain clinical parameters are explained for prediabetes for diagnostic purpose. So if we can diagnose the disease at early level, we can consider that Lakshanas as Bheda also, Yakti also. Yakti means the Lakshanas of the that's the fifth stage of Kriya. Coming to the conclusion, there is an interesting concept which is explained under Prameya Vidhana Vicharaka, that is concept of Vikara, Vikhara, and Bhava, Abhava. So Vikara, Vikhara means which is a complete reversal process. This makes it differ from the Vidhana of a disease, which means the reversal is possible. So how it is possible? We can arrest the progression by inhibiting the factors which increases the progression of the disease. We have to address whichever factors which increases the progression of the disease, that makes Vikara, Vikhara, and Bhava. At the same time, why the disease is progressing? Because it is getting compromised. Vikara, Vikhara, and Bhava is getting compromised, and that is the reason why the disease is progressing. And under the context of Vikara, Vikhara, and Bhava, Pratilisheshas are mentioned. So these Pratilisheshas include at different levels it is explained, which means the acute onset of the disease and the slow progression of the disease or chronic complications, like as different stages are mentioned, just like Shikra Vigara Chalanam, Mahadi Vigara Chalanam, and Ubhadra Anubhavam. So all these are different levels of manifestation of the same disease. In any stage, we can control the disease by inhibiting the progression from one to other. So this is the importance of Vigara Vikara Bhava, and that is why Acharya specifically explained this concept under the context of Prameha. So an early primary prevention is possible in prediabetes if your understanding is at the level of Kshatriya Kala. So this is my point is in the first slide I have mentioned there is an unseen gap which exists between the overweight persons and obese persons. So the gap is actually filled by the pathophysiological mechanism which is progressing from insulin resistance to the diabetic state. So in that state, the preventive modalities or the Prameha Chikitsa itself can do effective treatment or effectiveness in the patient if you are following the concept of Bhagavata and concept of Prameha Chikitsa under this context. Thank you.
Thank you, Doctor, for the clear and insightful presentation. With this, we come to the end of the non-competitive faculty presentation session. We sincerely thank all the presentations for sharing their knowledge, research insights, and clinical expertise. Your contribution truly enriched the academic spirit of Pre-Pack 2026. With this, we will be having a lunch break, and I request everyone to be assembled by 2:15 p.m. so that we can resume the afternoon session.
Thank you. We will meet soon. Please like, subscribe and share if you like the video.